Hello, hello. Hello. ఆడియో రాలేదండి, వస్తుందా? హలో. వచ్చిందా? ఆల్రెడీ 30 seconds లేట్ ఉంది సార్.
Presence of our MS sir, Dr. Hari Prasad, our academic director, Dr. Narasimha Reddy, our dean in charge, Dr. Jyoti Madam, our vice principal, Dr. Chandrasekhar sir, and our guest for the CME session, Dr. Natarajan and Dr. Jay Prakash. And now I request Dr. Biju sir to come to the dais. I request Dr. Biju sir to receive our MS sir, Dr. Hari Prasad Garu, to the dais. I request Dr. Anvesh to receive Professor Dr. Narasimha Reddy Garu to the dais. Anvesh. Now I request Dr. Vishnu Vardhan to receive Dean in charge Jyoti Madam to the dais. Now I request Dr. Biju sir, our head of the department, to receive Dr. Chandrasekhar, vice principal of the college. And now I request our medical superintendent sir to receive Dr. Jay Prakash to the dais. Now I request our MS sir once again to receive our guest for the CME, Dr. Natarajan sir. And now we'll start the lighting of the lamp ceremony. I request Dr. Biju sir to coordinate the lighting of the lamp ceremony. Thank you, sir. It is in our culture that we start an occasion with a prayer because we believe prayer brings enlightenment and success to the program. So now I request Dr. Kavya, please come on to the dais. I kindly request everyone please to stand up.
शुक्लां भरधरं विष्णुं शशिवर्णं चतुर्भुजं प्रसन्नवदनं ध्यायेत् सर्वविघ्नोपशान्तये अगजा आनन पद्मार्कं गजाननम् अहर्निशम् अनेकदन्तं भक्तानां वदापि गणपतिं भजेऽहं वदापि गणपतिं भजेऽहं वदापि गणपतिं भजेऽहं वदापि गणपतिं भजेऽहं वरनास्यं वरप्रदं श्री वातापि गणपतिं भजेऽहम् पुरा कुम्भसं भवमुनिवर प्रपूजितं त्रिभुवनमाध्यगतं मुरारी प्रमुखाध्युपास्थितं मूलाधार क्षेत्रस्थितं परारी चत्वारि वाद्यात्मकं प्रणवस्वरूप वक्रतुण्ड प्रणवस्वरूप वक्रतुण्ड निरन्तरो निखिलचन्द्रकण्ठ निजमामकर विद्रुतेक्षुरण्डं निरन्तरो निखिलचन्द्रकण्ठ निजमामकर विद्रुतेक्षुरण्डं कराम्बुजपाशबीजापुरं कराम्बुजपाशबीजापुरं कलुषविधुरं भूताकारं कराम्बुजपाशबीजापुरं कलुषविधुरं भूताकारं हरादि गुरुगुहतोषितबिम्बं हंसध्वनिभूषित हेरम्बं हरादि गुरुगुहतोषितबिम्बं हंसध्वनिभूषित हेरम्बं वातापि गणपतिं भजेऽहं वरनास्यं वरप्रदं श्री वातापि गणपतिं भजेऽहम् Thank you.
Thank you, Dr. Kavya. It was a wonderful prayer. The main purpose of conducting the CME, complex trauma of lower limb, why we have chosen this topic. It is because of two reasons. The first reason is increase in the road traffic accidents that which we are seeing now because of highways built and because of high-speed vehicles. And in India, it is estimated that around 1,500 accidents, major accidents occur in a single day. And the number of deaths per day is nearly about 450 per day. And major of these accidents can be prevented by two ways. One is by improving the road safety rules, as well as by training the surgeons in the emergency department. And the other reason is increasing the geriatric population. So once the geriatric population increases, even a small trivial fall can lead to a trauma. And most of the traumas pertain around the pelvis and the hip joints. So that is the reason that why we have chosen this CME for today. And we thought of giving tips and tricks to the postgraduates so that they can excel in their fields. Next, our job was to invite a national faculty who are experts in the field of complex trauma. So our head of the department thought it will be none other than Dr. Jayprakash as well as Dr. Natarajan, who are very well experienced in this type of traumas. And sir has invited them. And we are quite happy that they have accepted our invitation. And thank you, sir, for coming here along the way from Tamil Nadu. And now we think Dr. Our MS, sir, to say a few words and start the CME. Thank you, sir.
Good morning, all of you. So it's nice to see the ball rolling, the academic programs happening in all departments, preclinicals, paraclinicals, and clinicals on a regular basis. So as always reiterated, road traffic accidents have become a major problem. And as Dr. Hari Krishna told, and this safety training has been initiated from the government side also. Recently, the program has started and involving all orthopedic neurosurgeries and emergency, and all these people are given training, and reporting also has been there from the government side time to time. So regarding the CME on the complex trauma of the lower limb, so as anesthesiologist, it's always fascinating for the postgraduates in the Department of Orthopedics and from the anesthesia to attend arthroplasty, revision arthroplasty, arthroscopy. So these advanced techniques, but always, as always, the orthopedics, the basics of orthopedics is always learned from the trauma. So once you become an expert in the trauma, then only is an added advantage of having all these additional skills. So to develop these skills in trauma, so that's a major objective of this CME, which has been nicely initiated by the Department of Orthopedics under the leadership of Dr. Bizu and other professors like Hari Krishna and Vishnu, Anvesh, of all this. They have coordinated very well to organize this CME and inviting the eminent surgeons in this field. So we thank Dr. Jayaprakash Garu and Dr. Natarajan to come as guest faculty to do this program. And it's very nicely, this program is nicely designed. So this is of hope this will help you to fine tune the skills and learn the skills in the trauma. And it's the YouTube link also has been given. And please share this YouTube link for those who are not able to attend. So hope this will be of help for all the postgraduates and also the faculty also to fine tune their skills. So and from the as a medical superintendent, so I'm proud to say that the Department of Orthopedics is doing a great job. Apart from doing a regular trauma surgeries, interlockings and other things, and we are doing all this under as free of cost under Arogyashri, and we are doing replacements, knee replacements and hip replacements, and even arthroscopy, even for the patients who can't afford and who don't have this free scheme under Arogyashri, we are doing as cost to cost. So like 1 lakh for replacements. So we are doing at a very low cost for all those middle class people to afford this advanced management. So I wish all the Department of Orthopedics all the best for the CME. And thank you very much for giving this opportunity.
First, I would like you to know our guest speakers of today. Dr. Jay Prakash, he hails from Chennai, Tamil Nadu. He has done his undergraduation and post-graduation in the prestigious Raja Muttaya Medical College, Tamil Nadu. He is a member of IMA, IOA, and he is also a member of AO Trauma. He is a visiting professor of Madonna University Teaching Hospital, Nigeria, and he was instrumental in setting up the orthopedic department in that teaching hospital. Sir has done numerous spine surgeries, replacements, and complex pelvic fractures, pelvic fracture surgeries. Sir has also presented in various national and international arenas. Currently, Dr. Jay Prakash is heading the Department of Orthopaedics in Adi Parashakti Medical College, Melvarthur, Tamil Nadu. We once again welcome you, sir. Thank you, sir. And the other guest speaker is Dr. Natarajan. Sir also hails from Chennai, Tamil Nadu. Sir has completed his MBBS in the prestigious Madurai Medical College and his MS Orthopaedics in GSVM Medical College in Kanpur, Uttar Pradesh. Sir has also worked for 5 years in Hindu Rao Hospital in Delhi and has gained various experience in various surgeries. He's also done his fellowship in joint replacement and arthroscopy under the guidance of Dr. Gurva Reddy and Dr. Vidya Sagar sir. Sir has done his research work on clinico-radiological evaluation of osteoporosis, timing of tourniquet release in TKR and its effect on blood loss, study of placement and measurement of tunnels in ACL using a CT scanogram. He's also worked, he also has numerous presentations and publications in his kitty. I once again welcome you, sir. Thank you, sir. Now I request our HOD, sir, to start the CME.
Thank you very much. So I think most of it spoken by the Dr. Hari Krishna. Now we will start up with the CME. The first session will be started with Dr. Jay Prakash. And please stay back for the last session because that is going to be the most interesting session of all. Okay. And I want more of interactive session. It should not be a one-way talk. So all of us have planned in such a way that we won't be giving a talk as it is. All of us are not giving any talk. We're going to discuss on the X-rays. We're discussing on the various case scenarios. So I want all of you to have an interactive session and then, make it a little more lively and, clear your doubts. Clear your doubts here better than clearing the doubts in the exam hall. So I wish you all the very best. We'll start with the CME again, sir. Thank you, sir.
Has been discussing with us the pelvic fractures and its management.
I like to share in my experience and what I have learned from my seniors. Okay, so before I start, I'd like to ask the senior most PG students to come and occupy the second row. First row. I request everyone to come forward. So that we'll be a bit more close. So I can reach to you. As Biju told, we wanted it to be a more interaction session. Please, doctors from the last row, you can come in the front. Please come. Okay. Can I have the slides, please? Okay. So I am actually heading the department at 𝐂𝐴𝐺𝐿 Medical College, and this is, I hope that most of you will be knowing 𝐂𝐴𝐺𝐿. It is around 70 kilometers from Chennai, and I even work in Tambaram, where I work in a hospital called as Annai Arul Hospital as a consultant, and the names are not there where I work. So, and that is the college, our college building, and right now it's almost 5 years old. The institution is more than 30 years old, but there's a new block which has been opened recently, and that's where I work. And first slide, please. So when this topic was given to me, pelvic fractures, when I started preparing all the slides, rather than me talking about the routine theoretical part, which is almost available to you in most of the books, and you have heard a lot of lectures about the pelvic fractures. Pelvic fractures is classification, what are the priorities which will be given. But today I thought at the end of the program, at the end of my lecture, I thought at least the postgraduate, since it's a postgraduate teaching CME, at the end of the program, at least I wanted you all to be familiar and at least to do these 4 important procedures. And one is a pelvic binder, which another one is pelvic packing, and third one is a pelvic external fixator, and the last one is SI screw fixation. These are some of the most important procedures which can be done in the emergency procedure. Okay, and once you graduate and you go become a consultant and you work in an emergency, the first instant itself, you are not going to go and ask to go and put a pelvic plate or fix the plate in the back or buttressing plate, whatever is it at the advanced. But you must be able to do at least these 4 important procedures when you see a pelvic fractures. Okay, and you must not be once the senior consultant asks you to do some of this, you must not be in sin. I'm not aware of these things. These are basic things which at the end of your 3 years of post graduation, you must be at least aware of this procedure, and you must be at least confident enough to do this. So that's what I thought, and I immediately struck to me. It was a bit late, so I thought we'll have a small workshop on the external fixator also. So that's why we had 2 stations planned for that. And for the pelvic binder, next slide, please. Where is it? Oh, chop out. So once there is a pelvic fracture, you all know that we are all aware that the patient is going to be in a hypovolemic state because of the bleeding, and the bleeding is mainly 80% is mainly because of the venous bleed, and partly from the osseous fracture ends, it oozes into the pelvic. Next slide, please. And partly because of the fractured site where your bleeding happens. Third, less than 10% is going to be arterial. Okay, and once the patient at the hypovolemic shock is not picking up, the mortality rate is almost going to be very high. So at least if the first 2, if you are able to stabilize the patient, and you're going to correct this hemodynamic status, you will actually save the patient. The last one, it requires a team of experts where you need an intervention radiologist and all those things. If you are in an institution where it can be done, that is good enough. Otherwise, there are other procedures which we'll discuss, which you will have to go ahead and do it. Okay, right. Next slide. So that we all know that the anatomy of the pelvis, and it's very closely associated. All the vascular structures, important vascular structures, are very closely associated, and they run very close to the pelvic true and the false pelvis, especially the pelvis, and they are more prone for any injury and bleeding happening inside the pelvis cavity. Okay, so once the pelvis opens up, so there's a very big cavity, and there is no tamponade effect. Okay, so it starts here, and once it is once the pelvis is unstable, whatever hematoma is getting organized is also not will not allow to arrest the bleeding. So our main principle is to provide some amount of stability to the pelvis so that you can reduce the volume of the pelvis. At the same time, you can once the volume of the pelvis is reduced, at the same time you give some amount of stability, the fracture hematoma gets organized and it stops. Okay, this is for the venous as well as your the osseous bleeding which happens. An arterial bleed is a high pressure bleed which is very, very difficult to arrest. In those situations, if you are working in a periphery where then you can try other methods. Next slide. And a CT scan will definitely help you to tell us about the fracture. In all pelvic fracture, we normally take a CT scan, and in suspected cases, we can do a CT angio also. Will tell us whether it is going to be a venous or an arterial bleed, and based on that, we can intervene and stabilize the patient. Next. So a pelvic binder is a simple procedure which once you receive the patient in the ER, you can apply it. Normally, nowadays, we have a ready-made suit which all companies provide us, a pelvic binder, and which you can apply it around the pelvis. And there is a procedure that video probably is not playing in this. I can tell you, the pelvic binder, the principle of applying a pelvic binder is, it's very important that all polytrauma patients, you will have to take care and do a good log rolling, roll them over, put the pelvic binder inside so that it centers in the greater trochanter. The pelvic binder must be centered in the GT. And you can roll to, at the same time, the extremity must be internally rotated and held, okay, when you are applying the pelvic binder. So whenever you have, this will be very helpful when you have an AP compression fracture where you have a pelvis is opened up wide. It actually helps. But in a lateral compression fracture, you have to apply this one in caution because it gives some amount of more amount of compression from the when you try to put a tight pelvic binder. If you don't have a pelvic binder as such, you can even use a normal sheet which is available in the theater or in the ER. You can just fold them and wrap them around the pelvis, and you can just use the arctic clips to just hold it in place. So this is a simple procedure before you shift these patients to the investigations like for the X-ray and the CM. Once we suspect a pelvic fracture, so you can give a pelvic binder before shifting them. Next. So the next procedure is a pelvic packing. So this most of the time you can always help do it along with your general surgeon, but every time you will not have your general surgeon friend to be with you. But it is better that even if you go in your peripheral postings to a general surgery, you must learn this approach. Very important. A midline lower abdominal approach is very important. And the fenestrine incision, both these approaches is always very important for you to learn when you do your peripheral posting. Always learn this approach, and this approach will help you in doing this type of emergency procedures. And once you want to do high-end surgeries in the pelvis, these incisions and techniques will be very helpful. So never, when you go for a general surgery posting, don't just skip the theater. Whenever they have these type of lower vulnerabilities, go and see how they approach it, what are the structures which are important, how can we go and do this procedure. So the pelvic packing is another important procedure where the patients the vitals are not picking up and the patient is not getting stabilized. You are there in a periphery where you cannot do much. In that case, when you're trying to do your external fixator, you can open up the pelvis and do this packing. So we'll just see a small video of it, how you can do the pelvic packing. So that's a lower abdominal midline incision where you incise the skin and the subcutaneous tissue. Can you just actually, I had an edited video of this, but you can put it as 2. So this procedure normally it will not take you more than 10 to 15 minutes time if you're doing it. So once you incise the skin and the subcutaneous tissue, there is not much of important structures lying down over there. You will get your rectus fascia over there. In the midline, you can incise the fascia, and very carefully you will have to take underneath. Once you open, you'll see the space and you will have the bladder. The only thing which will come in the way is going to be your bladder. So that's a fascia which is covering the rectus. In the midline, you just open it up. You can see both the rectus. And you retract the rectus, you will feel the underlying fascia. Once you incise the fascia, you will be in the retroperitoneal space. So when you're after retracting the rectus, posteriorly, you will have the fascia. You have to be very careful in just incising that, because behind that will be your bladder. So that is the only point where, apart from that, this is a very, very simple procedure. See, you can just retract the bladder with another. You can use the general surgery long deverse retractors, where you can push the bladder to one side. And most importantly, you will have to pack into the true pelvis. So that's the last fascia which is being incised. And now you are into the retroperitoneal space. You protect the bladder, and you can start using the pads to pack it up. It's normally you, for an adult, you can pack 3 packs on either side. 3 packs on either side. If it's going to be a pediatric age, it is 2 packs. So this will definitely help even after doing a good resuscitation. You are not able to, the patient's vitals are not stabilizing, or it is not static after, in spite of all your blood transfusion and your fluid resuscitation in the theater. When you're planning for an external fixator, this can be combined together. This will definitely help, and you can open up in the next 24 to 48 hours, slowly remove the pack. If still there's going to be a bleeding, you can still repack it. Okay. So you can pack 3 packs on either side, and you can give a tight closure. Okay, you can stop the video. Next slide, please. So the next one is how to apply an external fixator. And there are 2 methods. You can actually try this one, external fixator, which can be either, it could be just a temporary stabilizer, or it could be even a permanent, where if there is going to be an open fracture where you cannot plan for a delayed internal fixation, you can still use this external fixator as a permanent external fixator. And there are 2 methods by which you can pass the put your pins. One is the anterior iliac crest, and another one is the supraacetabular pins. The anterior iliac crest are much more easy, because everyone can feel your own iliac crest. It is very easily palpable, and where you can easily put your pins, we can have. But the supraacetabular pins are the most strongest pins if you are able to apply. And this technique, you definitely have to learn it and master it. So it's very important for you putting your external fixator. So the supraacetabular pins are very, very, and most of the time you will need a C-arm for that. You cannot, even though you can have a landmark, but it will be helpful if you have this intraoperative C-arm to how to apply this. Okay. And you can, for the posterior ring, you can use the Gans clamp, and even you can try to put an external fixator in the iliac crest, which has been described, but I have not applied any of both of these things. So if you look at the picture, actually, this is a video. So if you look at the pins, so you can, the lower pins are from the iliac crest. If you try to compress them and see, there has been not much of a volume reduction in the pelvis, the iliac pins. And moreover, the table of the iliac table is very, very thin, and you always tend to perforate it very easily. Perforating the iliac crest inside or outside doesn't matter. You can even get a good purchase, but you must remember that if you are not well versed in doing a supraacetabular pin, you can go ahead and do an iliac crest pin, because these are going to be a temporary stabilizer of the pelvis. You are not going to apply it as a permanent solution for the pelvic fracture. These are temporary procedures where you are going to stabilize the pelvis, allow the fracture hematoma to get organized well, reduce part of the volume, intra-volume of the pelvis, so that the bleeding and everything can get arrested. So it doesn't matter if you go pin your iliac, the pins perforate the iliac, the cortices of the iliac crest. Can I have the slide, please? Slide. But the supraacetabular pin, you just remember, if you are trying to give a good compression from here, you hold the pins and you try to give a good compression, you can see the true pelvis volume will definitely reduce. And so that's why I said that the supraacetabular pins are very much more stronger if you apply it. Next slide. So how do we apply a supraacetabular pin? So normally it's a landmark which in a normal individual, it is very easy. You can just go down the ASIS around 3 to 5 centimeter down and go to around 2 to 3 centimeter medially. You can reach up to the pelvis. But once the pelvis is opened up, it is very difficult to get that landmark for a open pelvis. In that case, what you can do is you can use a shank spin in the iliac crest as a joystick to help you to just get this view. The obturator outlet view is a view which will be required for you to apply the spin. Obturator outlet view. And you know that an obturator outlet view, you just tilt the C-arm. This is a video which is not playing, sorry for that. And you can tilt the pelvis, you can see C-arm to 45 degrees and you take a outlet view. So that's the image which you have to aim for. You get a normal triangular shape in the supraacetabular region. And when you get this picture, you can put a stab incision right in the center. And after doing your finger dissection or with the help of the artery forceps, you will be able to reach, you can push in the sleeve, and then you can put the pin. And the pin has to be directed a bit medially and a bit superiorly so that it goes into the most dense part of the bone where you have a very good purchase. Okay, so that is how you apply a supraacetabular pin. It is very difficult for you to apply without the help of a C-arm. So you try applying it with the help of a C-arm. Get this view, get this triangle in teardrop view right in the center. You make a nick, you'll be able to reach to the supraacetabular, and you can definitely feel that the strength of the pins. Can you play the video? So this is the anterior inferior iliac spine. Can you just fast forward it, please? These are the instruments normally. This is a EVO video which is available there in the YouTube. Anybody can watch it. So these are the normal instruments. We need a long shank spins, sleeves, which will be required to insert the pins. Next. And a T-handle. You need the connecting clamps as well as the normal shank spin clamps. Can you just fast forward? So that is the anterior superior iliac spine, inferior iliac spine, and that is the suprapatellar ridge. So you can see from the anterior superior iliac spine, you drop about 5 centimeters down and you go around 3 centimeters medially, you will reach exactly the suprapatellar acetabular region. And this has to be directed inwards and superiorly. So it is very easy to look into the model and do this. But when it comes to a real situation where you have to deal with the pelvic fracture patient, you will not have this anatomy where most of the time it is opened up. So you will not be able to. So that's why in order to get this, you need a C-arm. So you can add one shank spin right over here in the top, and you can use it as a joystick to just get the pelvis to get that view, and you can pass the spin. So after passing the pin on either side, you can just connect it with your normal regular shank spin clamps and with a connecting rod. Oh, that's how you can just connect it. So before tightening, you keep the center connecting rod loose and you use the shank spin and give a compression. You can see that it compresses very well. And finally, you connect it with a connecting rod tightener. You can just tighten all your nuts. You can even add one more shank spin above this, because that is a very large space where you can accommodate 2 shank spin inside. You can accommodate 2 shank spins. So this is a more stable fixation than your iliac crest external fixator. If you want, you can add another shank spin also to add some more amount of stability to the pelvis. If you're planning it for a more definitive treatment where they have done a colostomy and all those procedures where it's going to affect you to do an internal fixation at a later date. But if you're going to just plan for a temporary stabilization, a good single shank spin will do good enough for stabilizing the pelvis. And lastly, you can. In order to add stability, you can use a normal, rod to connect both these fixator. It adds more stability to your fixator. So applying it in the iliac crest is a very easy procedure where you can just most of the time this is the pelvis. If there is a fracture, it might be associated with severe edema, and sometimes it might be associated with the moral level lesion also. So what you can do is you can still palpate, make a small nick, and this also you can see it in the C-arm also. Both the views, you can put your inner table and outer table K wires, and in between, if you can just go and pass in your shank spin. Never mind if it is going to perforate the cortexes inside or outside. Don't worry about it. As long as it is going to have a good purchase in the crust, and you feel that your shank spin is strong enough, that is enough. So you can use 2 pins on the iliac crust, just behind the anterior iliac spine, and another one is in the tuberosity, and you can connect it with the clamps and rods. So this is a very, very important. You can stop there. It's an important procedure which once you complete, you must be able to do it as an emergency procedure as you become a consultant. So with that, what I'll do is we'll have 3 senior PGs to go to 1 table each. No, anybody? So we'll just have a 10 minutes of where's the company person? நீங்க அந்த பண்ணலாம் உங்களுக்கு இன்ஸ்ட்ருமெண்ட்ஸ் கொடுக்கிறதுக்கு. Wait, no? Yes. So I want you to cover the pelvis, feel for your landmarks, and 1 cover is okay. அப்படியா? Okay. One of you can hold the pelvis. Okay. Another one will. No. Come this way. Okay. Right. Now, I want you to just palpate each and every landmark and tell me. Will you palpate and tell me, no?
This is the pubic symphysis, sir.
Very good.
Sir, anterior superior iliac spine.
Very good.
Just we have to come 5 centimeter below
Mhm.
and 3 centimeter posterior to get the entry point for the superior acetabular entry, sir.
No, no. 5 centimeter below.
And
And
medial,
3
3
centimeter
centimeter medial.
You palpate and come and see. Okay. Right.
Yes, sir.
You can feel it.
Yes, sir.
Okay. So it is 5 centimeter down and
Down 3
3
centimeter.
centimeter medial. Okay.
The-
That's where
this-
you put your
Shan spin, sir. For
and your sand spin is directed which way?
it should be it's inside and
No,
medial.
you must get your pelvis into picture.
Yes.
So, you know the pelvis is like this, and
Yes, sir.
the pelvis is going to be like this. So your sand spin also must go in that degree.
Yes, sir.
Okay, it's a rough calculation of around 20 degrees, 20 to 25 degrees. You tilt it medially
Yes, sir.
and superiorly.
Superior.
If you go inferiorly, what are the things which you are going to hit?
So bladder
You
we
will-
can injure.
You can go. You will enter into your true pelvis. Where
Yes,
you
sir.
have your bladder and other things.
Yes,
So it has to be inferior and superior.
superiorly and
Okay,
medial.
because that is where the bone is very, very strong.
Yes,
Right?
sir.
You get a very good trabecular pattern.
Purchase. Yes.
Okay, right. Okay, right. Stabilize the pelvis.
I am palpating the anterior superior iliac spine. I will come 5 centimeter inferiorly and down. Yes, sir. And 3 centimeter medial. Here I will take the entry point. My direction will be superior and medial, sir.
Now again go.
Yes. 5 centimeter.
Where is it? Anterior. That is anterior.
Yes. Yes.
Just below.
Just. Yes. Superior and medial, sir. I will-
What is the view you look for in the CR?
Outlet view.
Operator,
Obturator.
outlet,
Outlet view.
and what do you look for there?
Superior acetabular.
You look for the triangular tree
Triangular.
drop. That's it. Anterior, inferior iliac spine, just below that. Here you palpate and see what is there.
Acetabular.
You don't go there. That's a superior part of the sternum.
Yes.
Okay, so just below the anterior, inferior iliac
Inferior.
spine, you check. Deeper. You need this long shan spins. Whenever you are planning, you need this long shan spins. which is 32 mm threaded shank spin, which is required. Hold the pelvis for her. Hold it down. Yes, very good. Yes, yes. Anti-inferior iliac spine. Just below that. Yes, good. And directed medially. Okay. Give pressure. Go some more. Good. Right. Right. Now you can just feel. Now. Connectivity. Take 2 short rods, 1 short rod long and 1 short rod. Rods. No, rods. Another one long. Pin to pin. Ten, 14, 10, 11. Good. This is what I was telling you. Have pin over here and you try to give some amount of compression, just imagine that I have a pin here and I'm trying to compress it. Not much of compression will happen. But you see the supraacetabular pin, once you operate this, you can see that it closes up very well. It closes up. So that's why a supraacetabular pin is more stable for whenever you're planning for an external fixator. Okay. But if well, don't try it. You can still go and do if you're not comfortable, you're not that confident to do a supraacetabular pin, you can use, as I told you, you can use the C-arm. And if you're not comfortable in that, you can still go and do a iliac crest external fixator, which is just a temporary stabilizer. But more definitive procedure, if you want to use the pelvic for a long period of time, it's always the supraacetabular pins. So later you will try the iliac. Okay. We can use how to put the iliac. Okay. So one by one iliac and the so these are going to be here. You can, after in the lunch time also, you can try it again. Okay. Right. So the main thing is at least you must be very confident in doing the pelvic external fixator. Okay. Definitive fixation you are going to learn once you attend a few fellowship and you are under someone who has been doing this pelvic fractures regularly. Shall we proceed with the talk? Yes, yes.
Closer you bring it, better.
So the closer you bring it towards your, it's better. It gives more amount of stability. You can add another pins also here and connect these two. Okay. So normally it will be very close. The patient will be lying down like this. Normally it will be in the other way. Just
loosen it a bit and
so that
bring
it will
it
be like this.
Yeah, it will be in the anterior actually.
Right. Because these clamps are the new AO clamps where you the same as that one. You can rotate it. All our clamps can rotate 360 degrees. Yes. Okay. The same way.
The same it comes up around anterior. Comes around here.
So it will be something like this. Okay.
Patient lying down. Right.
The last procedure, which this procedure we can actually, most of the time we plan it as an elective, but you can even do this one as an emergency procedure also. And if your anesthetist is willing and you along with applying an anterior external fixator, if you are trained in doing this, and this is a percutaneous fixation of the posterior iliac ring. And there are different methods of stabilizing the posterior iliac ring where you can use a 90 degree plate, you can use a butters, and you can use it by you placing the pedicular screws also in the posterior superior iliac spine and stabilizing it with a rod. But the most important, it has been proven that the percutaneous sacroiliac screws gives a good amount of stability and compression to the posterior ring. And if you're able to put one or two in the posterior aspect when there is an opening or a fracture of the sacrum, it gives good amount of stability. Next slide, please. So when is it indicated? It's most commonly indicated when you have a sacroiliac disruption, a sacral fracture, and that must be not in the foraminal. A foraminal is not indicated for that. And when you have a combination of both. And when it's contraindicated, a failed close reduction. The most important thing is you will have to get the sacroiliac joint reduced before trying this one. There are different techniques by which you can use a joystick or an external fixator method by which you can reduce the sacroiliac joint before. And it's very, very important for any procedure which you are trying to do closed, you will have to get the reduction first. That's a main principle. So get the sacroiliac joint reduced by a direct or an indirect method, then you try to pass it. If you are not able to reduce it closed, then there is no point in trying to attempt to do a percutaneous sacroiliac joint fixation. And a mal-reduced sacroiliac joint is a contraindication. Presence of comminuted fragments and debris in the fracture site, when you see it in the CT, you don't try to attempt to do this because you will not be able to give good amount of stability. And in a very obese patient, never try this as a first procedure. Once you become an expert, it's because you need special type of instruments for doing it in obese patient. You need a very long K wires, long screwdrivers, all those things are required. And sometimes a CM is very much important for this, and you will not get a very good picture in an obese patient. So if you want to try it, you try it in a very lean patient to start with. But this can be definitely done along with your anterior external fixator, which you are trying to put. You can still go ahead and do this procedure within a few minutes. Okay. So it's better that if you are able to give the posterior stabilization in the emergency procedure, also we can do if we have the facilities. Next. Most important thing you will have to remember when doing this procedure is the sacralization of the lumbar vertebrae. So whenever there's a sacralized lumbar vertebrae, it is very, very difficult to put the sacroiliac joint screw, and never try to attempt to do that. The reason being, you can see that the sacralization is nothing but failure of segmentation of the lumbar vertebrae, and it's attached to the sacrum. And that is easily, you can see that if you draw a line along this iliac crest, it normally passes in a sacralized vertebra, it passes at the disc space. Okay. And in a sacralized vertebra, you can see the first foramina will be round, and whereas this will be more elliptical, round, oval in shape. Okay. So you can, the sacralized vertebra may be on bilateral, or sometimes it may be unilateral also. Next. So that's the reason why I told you, you'll have to get the screw right over here. Right over here. Okay. So here you have a very, very narrow zone. I think so. You can put this. Next slide. You can see when you're trying to put a screw, it has a very, very narrow zone where you have a chance to enter into your sacrum. So in a dysmorphic sacrum, never try to do it in the first vertebrae. It's very, very difficult. You will have to go a level down. Okay. Next. And there are never different journals and people support to that sacroiliac joint iliosacral screw percutaneous gives a good amount of stability for the posterior ring. Next. These are the very essential CM views which is required to do this technique. You need a good, good lateral view. You need a good inlet and an outlet view. These three, inlet, outlet, and what is a good AP, lateral, and an inlet view? The next slide, please. When you take a good lateral view, you must see to that you get the iliocortical density, which is on either side. Both must be superimposed. You must not get a iliocortical density one above and one below. So the patient must be positioned and the CM must be positioned in a good way. And you can see the greater sciatic notch, it must be seen as a single. It must not be seen as a double shadow in a lateral view. Okay. And that's an inlet view where you must be able to see the body of S1. And that's the outlet view. outlet view, normally a good outlet view, the superior pubic rami normally passes to S2, where you must be, okay, that's a good true AP outlet view. Next slide, please. So this is not a good lateral view. On the one over this side, you can see the iliocortical density is a double shadow. Okay, whereas a true lateral view is where you see a single iliocortical density and a single sacroiliac joint. It's a superior sciatic, greater sciatic notch. Okay, next. So these are the different reduction techniques which you can use. You can use a shunt spin just in the iliac crest to just clamp it, and you can use the ball spiked. If it is going to be a vertical shear fracture, you can put a shunt spin in the iliac crest and another one in the supraacetabular region, and you can help to get the reduction. Okay. Next. So the most important thing is in the OT, you take a good AP lateral inlet outlet view. Next. In the lateral view, this is the first point which you normally do. You take the K wire and you just mark the superior border of S1. Okay, you must get this orientation very well. Otherwise, you will be taking an, even if you don't get this orientation properly in the this picture, you will be taking a lot of exposures and still you will not get it right. So you must see that the first pin is the sacrum is oriented this way. If you want to go antero-posterior, you have to go only in this direction. This is what I just want to tell you. You want to go antero-posterior, you have to go this way. You cannot go this way. Normally, you tend to go above and below. Okay, so you have to orient it above and below like this. Okay. Next. Next slide, please. That's a video which is not playing. Next. So that is the entry point, right? Just below the iliocortical density is a green point, is where you enter. And once you enter, next slide, you see to that you pass into just above your S1 foramen. Okay. And you take an inlet view, you see to that you are passing into the body of your S1. Okay. So it is very, very important. If these three views and the most important principle, first landmark, first draw the line, and you will get your sacrum, how it is, you get it yourself oriented. So you will be able to get the screw right. So if there's any questions, I'll be taking it a bit, I'll take it after the talk, Dr. Biju. So thank you very much. And again, once again, sorry, we'll.
Thank you very much, sir. That was a great presentation, sir. Now I would like to call Dr. Biju Ravindran, sir, head of the department, Narayana Medical College, for a talk on treatment options, fracture neck of femur and elderly.
Back. So, good morning, everybody. At the outset, first, I would like to thank both our speakers for coming all the way, taking trouble. They came down late night and got up early morning and, came all the way to make this presentation. First of all, my topic was treatment options for fracture neck of femur in elderly. So, I want to ask, probably at the end of this presentation, what and all we have been doing now and what and all we have done. You will have a question in the head, what we are doing is right or wrong, or whatever is going yet to happen. When will we start doing the right thing? Okay. There are various options for this, fracture neck of femur. Probably, Deepak, a case of 60-year-old man, 65-year-old man with a fracture neck of femur, 60-year-old man with a fracture neck of femur. What do you do here in our hospital? You do fracture neck of femur. How many of you truly do? 60-year-old, where is which unit is that? Anvesh unit. Anvesh's unit for a fracture neck of femur. Do we do total hip replacement or do we do something else? Bipolar. We do bipolar. Most of us do. Fracture neck of femur, we end up doing bipolar. Arogyashri, you'll be having some scheme, will be having 30,000 rupees. What they can afford, we are doing a bipolar. Are we doing this right or wrong? Is what we're going to take home to the end of this message of this whole talk. Okay. With that, as you know, I'm not going to go into the detailed part of it. See, basically, intracapsular fracture neck of femur, you have 50% of all the fractures of the hip joints come into this. Okay. Most commonly seen in the elderly of 6th and 7th decade. And mainly it is due to any trivial fall or a trauma or any osteoporosis. Because of that, stress fractures or all those. I'm not going to go in the blood supply because as all of you know, why this is so notorious, this neck of femur, is because of it going in for non-union and avascular necrosis because of a very precarious blood supply. Because of that, it has to be very carefully dealt with. And most of the time, in younger individuals, it is causing a problem rather than the elder individuals, because we try to go for osteosynthesis in younger individuals. In spite of giving, osteosynthesis in younger individuals, it can still go in for avian, or it can go for non-union, right? Can I get the thing opened up, please? Yeah. So it basically depends on the trabecular pattern. We decide who are osteoporotic, who are not osteoporotic, what is the kind of treatment we do, depends on the osteoporosis of the individual. Okay, next slide, please. Yeah, so what are the high-risk patients? Yes, it happens in elderly. In this elderly, which are the high-risk patients going in for, what replacement or want to go in for modular or cement or uncemented, whatever it is. So it's mostly 70 years more, osteoporotic individuals, postmenopausal female patients, obese, diabetes, alcoholism, renal disease. Next, bedridden patient, institutionalized patient, poor health, smoking, and people who are on long-term drugs of, your PPI, antipsychotics, and your corticosteroids. Okay, these patients have the 70 years old itself is a risk. All these patients having a comorbid along with that makes it even more riskier. Okay, it is common after 60 years. The hospital mortality rate is 6% and a 1-year mortality rate is 25%. Unfortunately, in India, what is happening is we don't have a national registry, or we don't have a district registry, or we don't have a state registry like they have abroad. Abroad, every fracture you need to put it on the web, database. We don't have such a database. Because of that, we are not able to tell exactly what is the outcome of what you're doing, how many patients are alive after we treat. We don't have such good follow-up or a data. Because of that, we're not able to give the right Indian data. These are all abroad data, what we're having. Okay, next slide. As you know, they're classified into based on the cause, based on the anatomical location, based on the angle of fracture line, and based on the fracture displacement on the trabecular. Based on the cause, it will be divided into stress fractures, pathological fractures, post-traumatic, or the irradiation, post-irradiation. Based on anatomical landmark, it can be a subcapital, it can be transcervical or a cervicotrochanteric or a basis cervical. All of them goes in for chance of union and non-union is very important. The third one has got more options of going in for. This Gardens classification, I'm not going to go into the classification details as per se, because here we're treating on the treatment options we're going to deal with, and that too treatment options in elderly. So I'm going to skip the basic clinical features and all that. I'm going to think of how to treat this patient, and I'm going to skip the younger individuals also. How to treat the elderly patient, because now we are more into a geriatric population where we are having how to treat them. And the most difficult aspect is treating geriatric population with such fractures. Next. So this is pause, yeah. So initially we take an X-ray, okay, an AP view and a lateral view, or a, most important, a cross-leg lateral view, okay. A cross-leg lateral view is a better X-ray than having a, your frog leg view or something. So you can see the extent of the fracture line, the angle of the fracture, how much posterior wall comminution is present, how much amount of osteoporosis, is there any arthritis or pathological fractures, and associated fractures. Most important is your posterior wall comminution. Osteoporosis is a very important thing to be seen on an X-ray, which most of us tend to overlook it, and we treat the patient such a way. Okay, next. CT scan is mostly done in case of undisplaced fractures, associated acetabular fractures, and pathological fractures. Next, MRI usually is not done until if it is for knuckle fracture, stress and pathological. Usually neck of femur fracture MRI we suggest post osteosynthesis for AVN or for non-union, all those things we look for an MRI. Otherwise, it is not usually taken in case of an elderly individual. Now, any fixation, any whatever treatment you do, first we have to define our goal. It is like, you know, if you want to go to a place, we need to know what is our destination, okay, and we need to know how long to travel. Same thing, we need to know what the end goal is, okay. This is the most important thing to be kept in mind while treating a neck of femur fracture, which we don't often do. We see a neck of femur fracture, we don't go into much of a history. We are now into an era more of diagnostic things we see and we just treat. So we need to, what are the goals? One, we need to restore to the pre-injury level of function. We need to do early mobilize. We can have, it should be easily mobilized. We should minimize the complication, avoidance of a revision surgery, and last, most important, cost effective. In India, it is supposed to be in the top notch. Next one. So this is the most important slide of all the whole thing. Why? You need to know what this patient's ambulatory level is. Is he a community ambulatory? Community ambulatory means he's going around in the community and everything. He's active. Is he a household ambulator? Only household works he does, not much of community work. Is he a non-functional ambulatory? That means non-functional ambulatory, he gets up, he goes to the user the washrooms and other things, or a non-ambulatory. These four things is very important, and you need to put them under this thing. This will decide the treatment. Medical history take up, cognitive history, and functional history. That means one more thing, someone of you told me, said you want to do a total hip. If the living conditions of the patient and the ambulatory status is not good enough, total hip replacement might become a disaster. Okay. So we need to know all this before getting into the real treatment per se. Next. So any pre-existing cardiac or pulmonary disease, any diabetes, any peripheral vascular diseases there, any thromboembolic phenomena, or osteopenia or osteoporosis. Okay. Next. Now this is a very important thing. A precognitive status is very important. Why? You will do the surgery, but then making the patient walk, understanding the physiotherapy. See, every surgery what we do, I believe the basis of every surgery, the most important aspect of surgery is the physiotherapy. That is why I trust the physiotherapy department very much. And I believe they are the strength of our department. And we need to be a little more interactive with them, which we are not. So most important thing is the physiotherapy will be quite difficult if the patient is an Alzheimer's patient or a CVA, Parkinson's or senile dementia, because they'll be unable to render or participate in your physiotherapy post-surgery. Okay. Now, earlier times, this thing was Do we operate or not on neck of femur fracture? We always operate with what we say. Earlier times, there was an option for us when we used to do post-graduation. We used to not even treat sometimes. There were so many different things we not used to treat. You just leave it as it is. It becomes like an excision arthroplasty, non-union, no pain. You can make the patient walk. I'm saying earlier around 30 years or 35 years back. So surgery is the treatment of choice is the underlying statement now. Okay, if possible, right? So what are the options? What we have? We have osteosynthesis, we have hemiarthroplasty, we have a total hip replacement. 3 options that we have. We reserve the first option for the younger individuals. So you are stuck with hemiarthroplasty or a total hip for now, right? Next slide. As I said, younger individuals, osteosynthesis. Now, if it is existing osteoporosis and age-related changes, there is increased risk of non-unions. That is why elder patients, we don't tend to go for osteosynthesis because the rate of non-union is more, rate of AVN is more. And older patients, if you put a osteosynthesis, making the patient non-weight bearing and also very difficult in older individuals. They don't tend to follow you. The younger individuals do. So arthroplasty is the main treatment. Next. Now we have controversies and choices here. We have 3 options: hemiarthroplasty, total hip arthroplasty. Okay. What are the controversies? See, we have choices, but we are even given controversies along with the choices we're given. We are given implants. We are given choices. Now, I want to divide the treatment options in such a way for you. Hemiarthroplasty. All of us love to hear this controversies, fights. We are used to this kind of the Indian attitude is such, that we love to hear this controversies, gossips, and everything. So a little bit of gossip, a little bit of controversy in orthopedics. So hemiarthroplasty, is it unipolar or bipolar? Which is better? Then you want to use a bipolar, want to use a non-modular or a modular? Okay. You want to cement it or uncement it? The first controversy is there. Then you want to totally remove hemi, you want to do a total hip. Okay. Either it is hemi or a total hip is the next controversy. If you want to do a total hip, what you want to do you want to do a cemented or uncemented? The third one comes in. Or in between cemented and uncemented hybrid, a query comes in here. We're all stuck with this kind of things because in our times, there are, over a period of time, implants have developed. I don't know, many of you must have not even utilized these implants or seen the implants. I think probably JP sir's or Nataran sir's time, my time, we used to use this SP nail and angle blade plate, and all those implants. And there were times when we never have done an interlocking. In fact, K-nail was the most, especially because of subtrochanteric fractures. I think myself and Dr. Jayaprakash would have put lots of K-nails. During my second year is where I came to see interlocking. So how do we follow these implants? We have set up group of people who have structured these implants, biomedical engineers, a group of companies who have bombarded us with this implant. The next implant comes in. If one fails up, the next comes in, next comes in. Here, one small hitch is there. Probably in 2000, we were using, or 96 to 2000, we were using K-nails. That period of time, in the Western countries, they were using interlocking almost for the past 15 years back. That means from 80s, they were using interlocking. We started using interlocking in the late 90s. So we have a 15 years gap there. When we started using Thompson, the people already started bipolar 10 years ahead. So we were always back 10 years. Now, all these, Thompsons and bipolar has to be manufactured. When the US and the European countries switches on to a hemiarthroplasty, where does these all implants go? Controversy. It comes to the Asian market, and we have some time. We need to move on with the next level. And most of the time, what happens when they come to the Indian market, it becomes a very costly affair. Implants, unlikely, and we can still use bipolar and everything. But in America, you can't use a bipolar. For instance, Austin Moore and Thompson has been abolished in the US and in the European countries from the late 90s. And we have been using it from 90 to till date also we're using. And from 2011 onwards, the non-modular bipolar has been totally, kept restricted of not to use a non-modular bipolar. Here we are still using it. Okay. So coming back to this, hemiarthroplasty is unipolar or bipolar. As you know, unipolar has got a significant acetabular wear. Okay. Reduction is more difficult in a unipolar or a monopolar. And periprosthetic fractures are common in unipolar. So when we compare unipolar or bipolar, we have come to bipolar is better. Right? Next. So as you know, you have seen the bipolar. It has got an outer shell and inner shell. It has got a liner inside and a special design. You have movements in two planes. One in the outer shell plane and second in the inner shell plane, or between the native acetabulum and the outer shell. Next. So when we say bipolar, we know only one bipolar. We don't say modular bipolar. It comes to our head as bipolar, what we use as a non-modular bipolar. Abroad, when you say bipolar, it is a modular bipolar. There's nothing called as non-modular bipolar because that has been extinct since 2011. Okay. So there is a difference of terminology itself in the Westerners. So a bipolar process can be divided into a modular one or a non-modular one. A modular process has got an adjustable SEM. So because of that, you can adjust the length of the processes. And commonly used in India, what we use is the non-modular bipolar. Next. So this is the modular bipolar, which all of you have seen. Most of us have seen, very few cases have done here. So advantage of this modular bipolar is it can be converted into THR, better range of movements. Advantages of making an adjustment for limb length is good. Disadvantages, there's increased osteolysis of polyathlete, gets converted into unipolar over a period of time. Now we have converted. Now, first one, was it unipolar or bipolar? Bipolar is better. Then we said bipolar, non-modular and modular. Modular is better. We've come to that now, till that level now we have come down. Next. Now this next controversy was to be cemented or uncemented. Okay. So some studies, the problem is some studies showed that, cement has good amount of, strength and provides a very good stability and less periprosthetic fractures. Okay. The other studies showed the cement related complications were very high. These complications are not recorded properly in our country. So we don't know the exact, what is the percentage or whatever it is. Okay. And it has got less operating time. Other studies shows no difference in those two. So use of cemented, we have restricted to how use of cemented hip hemiarthroplasty, use osteoporotic bone and wide femoral canal. That is the underlying statement. Okay. Whatever processes. Now we have come to a modular processes. If it is an osteoporotic individual, we can put cement. If it is non-osteoporotic, we can put the uncemented. Next one. Now it comes, next controversy comes in. This unipolar, we are really telling it gets converted into unipolar. Then why do that? And why go for acetabular erosion and everything? It is better we can go for a total hip. That's why the controversy of hemiarthroplasty versus total hip arthroplasty comes in again. So advantages of total hip is one, as you all know, it has got a better function. Range of movements is good. The pain scores are better. Okay. Less acetabular erosion and better long-term survival. So now we have started from unipolar and now we have traveled the history all the way through stating that total hip is best option for a 60-year-old person. More than 60 years, you can go in for a total hip. Okay. Now the first question which Deepak was asked, we are using a modular, we are using a bipolar. Now we have to think, are we right in using it or not? Not entirely right, not entirely wrong, because of the cost effectiveness. Every fracture neck of femur, if you go do a THR, we will get bankrupt. So not entirely right to do it. So hemiarthroplasty disadvantages of total hip is also there. Increases dislocation rate, increases the outtake time and requires expertise. I don't believe these three are much of a disadvantage now in this era. OT time, bleeding time, all we can, and expert is also most of them are doing now. Next. Yeah, now comes cement or uncement is another headache now. We all come to a conclusion for a femoral neck fracture above 60 years, it is best to go for a total hip. Now, do I use cement or do I use uncement? What to do with it? Cement, now basically to know that, you have to know a little bit about the processes. So the cemented stems falls in two categories. One is a tapered stem and one is a composite beam. Okay, two things are there. Tapered stems are collarless, and the composite, and this mainly achieves the stability through the cement interface and the bone interface. There's some amount of subsidence happening. This micro motion, what happens, this is the betterment of the processes. Next one. So composite beam is a solid bond between the stem, cement, and thing. If you see the design of the process, next slide, you can understand this. Okay, since it's a taper stem, it is collarless. You have better stability. You need a cementing to better stability here. But if it is in this case, you have a groove down where the cement can get adhered to the groove. So a lot of people use the composite beam now. Next one, uncemented processes. Most of these are HPA coated processes or a cobalt chrome, in which either it is sprayed from totally, okay, it is fully coated or proximally coated. Okay, these are two types of uncemented broadly. Next one, benefits. Now we need to know, when do we use uncement, when do we use cement now? Benefits of uncemented: one, actively stimulates the osteoblast because of the HPA coating, and survivorship in uncemented acetabular component. Acetabular component uncemented for long standing of survivorship is better. Femoral component is not so. Got it? When you have an uncemented, the acetabular component survivorship studies shows more. The femoral component survivorship shows less. Less operating time, less blood loss, easier revision to do when you have an uncemented. Okay. Next one. Disadvantage: uncemented, the intraoperative fracture rates are very high. You must have seen, you get to have this trochanteric fractures or proximal trochanteric fractures or the sharp femur fractures. Okay. And there are short-term complicated pain is also present. That is because of a modulus mismatch between the cobalt chrome and your cortical and cancellous bone. Okay. Here, one more headache what it's facing is the fourth point. There seems to be a motion happening between the shell and the liner in the acetabular component. You put the, you put the shell first, then you use the liner. In the backside of that liner, there seems to be an erosion. That's called as the backside wear. Okay, it's very common. And for Indians, the last point is the most common, cost factor. Every neck of femur, we can't go in and operate on, uncemented total hip arthroplasty. Next one. Next one. Yeah. Benefits of backside, please. Yeah. Next one. Sorry. The benefits of cemented now. I told the advantage of uncemented. Cemented is survivorship in femoral component is, better in a cemented one. Optimum positioning is good. Excellent results in osteoporotic individuals and osteopenic individuals. And multiple studies shows what earlier weight bearing and the physiotherapy option of it is very good in these patients, and less rate of periprosthetic fracture. This is the benefits of it. Back here, more the operating time and blood loss is more in case of cemented. The complication of cementing, as I said, is always high. Increased rate of acetabular cup loosening. The femoral cup, the stem doesn't loosen out, but in case of cement, acetabular cup loosening rates are simply higher and difficult for revision. Next. Now we have one cemented processes, one uncemented processes. We said in cemented process, acetabular cup loosening is possible there. Here you're saying uncemented processes, femoral cup loosening is there. So we come to a solution of midway. Why don't we use uncemented for your acetabular component? Why don't you use cement for your this component? That is why this hybrid hip came into existence. Okay, where we use the acetabular component, we use as your uncemented component. And here, short-term there is revision surgery is relatively easier. It is cost effective, and fewer complications. But the problem of a modular hip is we don't have a long-term studies of modular hip. It's just been 10 years. Long-term studies, but 20-year long-term studies, we don't have that. We just have a 5 to 10 years or 10 years studies we have. And not multiple studies also is there. We need to have a little more better studies. Probably sometime later, you'll end up with some other complications and it'll come with a newer implant, newer version very soon next. Or probably it has probably been on trial in the US and Europe. We'll get to see it probably 10 or 15 years down the line. So these are the problems in hybrid now. Okay. Now, the last question comes, then when do I use the bipolar which I'm having? Cheap and best. US, they use it or not? Yes, they use it only for non-ambulatory patients. You don't want to waste time on operating time. He is not going to walk. You want to give pain relief. That is the only indication abroad. Non-ambulatory patient, you use that. That is why I said you need to know what is the pre-operative function of a patient or what is the ambulatory status of a patient. Understood? Next slide. So let us conclude saying total hip is definitely better than hemiarthroplasty. One, concluded out in elderly individuals with good pre-injury ambulation. Second, less than 70 years with good bone stock, unsymmetric total hip or hybrid hip is a good option. Both can be converted into a scimitar later on. A revision is a little easier. More than 70 years, there is always the chance of osteoporosis. You can go in for a total hip arthroplasty is the best option, both the acetabular as well as your femoral component. And hemiarthroplasty may be considered in elderly non-ambulatory patient. Next slide. Thank you so much.
Thank you very much, sir. The next session will be continued after a small tea break for 15 minutes. Kindly have your tea outside. Thank you.
అందరూ నమ్మచ్చు.
Okay. Will change, yeah? It will change on its own. Hello, hello. Hello. We'll change from there itself. Can you go to the first slide? Okay, once again, good morning to you all. And my topic, the second topic for the day will be complex intertrochanteric fractures or unstable intertrochanteric fractures. How are we going to manage? Okay. Can I have the first slide, please? And can I request one of the final year PG to come here? So before, can you just go down the slide to 5, 6, 7? Down, next. Okay. So before I can start, I'll just brief you about the classification of the intertrochanteric fractures. You know that we classify into A1, A2, and A3. The A1 is a simpler variety where it's a two-part fracture, and it depends upon the amount of the medial fragment in the proximal. We classify it A1, A2, and A3. And the A2 is nothing but the amount of comminution in the posterior medial aspect. It depends upon how much of comminution is happening in the posterior medial aspect. You classify it to A1, A2, 1, 2, and 3. And when there is a fracture on the lateral cortex, it comes to A3. Okay. And if it's going to be a fracture which is extending down to the lesser trochanter, it will be A3, 1. Just a transverse fracture at the level will be V2. And if it is going to be having along with the lateral wall, along with the medial comminution, then you call it as 3. Okay. So based on that, we'll go back to the first slide. Okay. Sorry, we have already seen what we are planning. So this one is, what do you feel, doctor?
Most probably A3, sir.
No.
Lateral.
It looks like a two-part.
That's a two-part.
It looks like a
Displaced two-part.
this is an AP view and that's a lateral view. You can see that it's a two-part. It's a simpler fracture. Even though it looks complex on the lateral view, it's a simple two-part fracture. Okay, it's a simple two-part fracture. And next one. And what has been done is a simple DHS fixation with the derotation screw, which has been done. Okay, next slide, please. So what about this?
Extended, sir.
Huh?
Extended or both?
This also looks like, see, whenever you are in confusion about the classification or looking at the X-ray, it's always better you just take a traction X-ray so that you will be able to classify it in a better way. Okay, so it also looks like it's just a two-part fracture. Okay, and it's a simple intertrochanteric fracture which can be very well managed by a dynamic hip screw. Next slide. So this was what it has been done, and we have fixed it with a dynamic hip screw with a derotation screw. Okay, right. Next.
This one, probably it has a more calcar medial spike. Probably it must fit into somewhere around A1, 2 or 3. Okay. It's a simple fracture, 2-part. Next slide. So what has been done? Since it has a very large calcar, probably you can do a cerclage wire first and you can reinforce, or you can do fixation and further you can add a cerclage wire. Okay. So, but the DHS has been done for the simple. So from this, you can confer that for all your A1, it's a simple fracture. What will be a treatment of option will be
Dynamic hip
screw with a derotation screw. Okay. Depending upon the amount of the medial fragment length, you can add an augmentation wire or you can just leave it as such if your reduction is good. Okay. Next slide. You can go and sit. Can I have the next one, please? Next slide. Previous one. Previous. Next slide. Okay. You can go and sit, doctor. Let me have another. So until 2012 and 13, even for A2 fractures, I was managing it with the DHS, because they are we call it them as a unstable fracture. We call them as unstable because there is a lot of posteromedial comminution. Okay, and so it belongs to the unstable variety. Okay, and now we have the concept of the PFN and other things, but before getting the become more familiar and more technically sound in this the PFN and other things, previously we used to manage even the A2 fractures by the DHS, but we were learned how to convert these unstable fractures into a stable one. Okay, the only thing is we have to do is converting the unstable fracture into a stable one before you put in a DHS. So if you are able to do that, learn how to do that, then the A1 and A2 can still be managed by doing a DHS. Okay, but we have better implants now presently, so we will come to that. But for a postgraduate, you must know what are the different methods by which how you can convert a unstable fracture to a stable variety and still go and put a DHS. Okay, right. Next slide, please. So this is from the textbook. I do not know nowadays. I very hardly see people, postgraduate students, opening the textbook and going through it. Okay, this is from Campbell. I am not sure whether the recent Campbell has this, these two osteotomies now. These are two important procedures. One is called as a Demand-Houston osteotomy, and another one is called as a Sarmiento technique. These are the two important surgeries by which you can convert an unstable A2 fracture to a stable fracture and still go ahead and do a fixation with a DHS. And you can add some augmentation. Definitely these type of fracture will definitely go in for union, but the problem is there will be definitely around 2 to 3 centimeters of shortening, which you have to explain to this patient. Okay, so have you all seen a Dimon osteotomy, Diamond-Houston osteotomy? Most of them you would have seen in the post-operative X-ray. Most of the X-rays where you treat a DHS with this unstable fracture, if you are going to put in a DHS, intraoperatively it will look perfect. But if there is going to be a posteromedial comminution, you see them walking and you see the second, third third review X-rays, and the second month and third month, they would have almost collapsed. You can see the proximal fragment would have sinked into the medullary canal of the shaft of the femur, and it would have nature would have taken care. So that is a nature's method of doing a Demand-Houston osteotomy. Okay, whereas but these patients will always come with you some moment of pain where the fracture will unite definitely. Okay, that's why we always say that the DHS is always a very, very serious, safe implant. Okay, okay. So the fracture will collapse, it will unite, it will stabilize and it will unite. But the patient will always have that. But intraoperatively, if you are able to stabilize this fracture by putting in a shorter screw, you can definitely avoid these complications. But this patient has to understand that you will have a shortening. Okay, right. Next slide. So here you can see in the lateral view, it's a very unstable fracture. Probably next slide, please. Okay, here it's a, you can see that it is a unstable intertrochanteric fracture. Okay, it's almost A3 where the lateral cortex is fractured as well as the medial posteromedial combination is there. Okay, right. Next slide. So intraoperatively, you plan and you want to do a fixation where there are a lot of situations we will have to compromise because we have to look into the cost of the patient. We will have to look into the as Biju told, we will have to look into the how the patient was walking. If he was walking before, you have to bring him to the ambulatory status, whatever possible way you can. To do a PFNA2, which is now the current trend of managing intertrochanteric unstable fractures, the patient has to spend more. But if still these unstable fractures can be converted with the similar amount of cost where you can put in a DHS and stabilize this fracture for just around 4,000 to 5,000 rupees, rather than spending somewhere around 20 to 25,000 rupees by putting a PFNA2. So here, what you do is you reduce the fracture as a routine. Next slide. You put in your guide wire at as you know that you always aim. Where do you normally aim when you're putting a guide wire in the AP and lateral?
The entry point will be just above the lesser trochanter, sir, at the level.
No, in the AP view, where do you want your guide wire to be?
Guide wire to be
in the neck.
Just at the center, sir, or little bit.
It is either in the center or just below the center. Okay, below. It must be in the inferior. And in the lateral, it must be in the center or it must be more in the posterior, which is where you have to aim your guide wire. Next one. So here, now you plan, you don't try to take you take a shorter screw. Normally you take around 50 to 55 mm of lag screw. You put it in. Next. And then you can use a short barrel plate. You can see that you achieve this medial cortical continuity. This is why you have to aim. You achieve this medial cortical continuity, try to push this fragment. You will see the greater trochanter looking apart right over your plate, which later you can do a cerclage wiring. Next. Okay, so this is, you can see now there is a posteromedial continuity of the fragment. The GT is out, the greater trochanter is out, but still you can still wire it to your you wire it to your proximal femur. Rather than wiring it to the plate, you wire it to your proximal femur, which is a very, very important technique. Okay, I have a video for that also. You can see that how you get your wire right across the proximal femur, which is a more stable fixation than wiring it to your plate. Never try to wire it to a plate. Okay, so this is called the This is called the Sarmiento's technique of converting a unstable intertrochanteric fracture to a stable trochanteric fracture. But because of the collapse, definitely these patients will have around 3 centimeters of shortening, and these patients must be able to, they must accept it. So our aim for all these old age people, most of the intertrochanteric fractures who are ambulant, our aim is to just mobilize them so that they will be able to attend to their normal daily routine needs, like going to the toilet, coming and sitting in the dining. So that's what we are aiming for. Okay. So in all those type of cases where you get a patient, you can still convert them and do a DHS. Okay. So that's why I put, today we have a different type of implants to manage all these fractures, but still you must know that there is a technique like this where we can stabilize these fractures. Next one. So here is another situation where you can see it in the AP. Even though you see in the AP and the lateral, it looks like something comminuted fracture. There is some amount of posteromedial comminution in this fracture too. In the AP view on the CM picture, it looks good. Next. So here, very often it might be a two-part fracture. It might be a two-part fracture, but when you're putting a DHS, you will fracture the lateral cortex. Okay. So how to judge that also, I'll show you how to judge that this fracture will, when you are trying to put a DHS, will definitely shatter the lateral cortex. Okay. We have a slide for that. Will come. So here, what you do is you put a shorter screw, you put in a short barrel, try to medialize the distal fragment so that the calcar gets into the medullary canal of the distal fragment. Here, in the Sarmiento method, technique, we had the continuity of the medial cortex with continuity with the medial shaft. Okay. But here you can see that the medial calcar goes right inside the medullary canal. Okay. So it is almost completely stable. Most of the time, our review X-rays, when you put an DHS, will be something like this. But the DHS screw would have come out. Okay. You could have seen most of the X-rays like this somewhere. Okay. So this will be a problem. Here, intraoperatively, you are converting this one into a stable fracture by putting a shorter screw, stabilizing the fracture, and you wire the GT to the proximal femur by a figure of 8 fashion. Okay. And this is a Dimon and Houston method of stabilizing a complex, unstable intertrochanteric fracture to a stable intertrochanteric. These are the two osteotomies which I really want you to understand. Okay. Right. Next. So here is a situation where this is not where this is a A3 type, A3. Okay, A3.3. Okay, the very unstable fracture. We always think whether to stabilize this or not, or to go directly to a replacement hemiarthroplasty with a long stem. We always think in our mind. X-ray, please. But if you try to put this patient in a traction view, you see that there is a good amount of medial cortical continuity. You still go ahead and do a PFNA2. Okay. But since there is no contact, next please. So this is about the follow-up. What happens? Even though the lateral the nail is going to act as a lateral pillar to prevent further collapse and of the head, if the fragment, the neck fragment is too small, it is very, very difficult. Okay, the neck fragment has to be relative, and there must be a reasonably good amount of calcar so that the principle of the PFNA acting as a lateral butters to function. Okay, you must have a reasonable amount of neck for that function to happen. But if your neck is going to be too small, it will not, the lateral butters effect of the nail will never stand. At one point of time, even further collapse, the head will start rotating and there will be a cut through of the implant. So that is what has happened in this case. Next one. Right. So the location of the primary fracture is very important when you're deciding on whether to stabilize this fracture or not. Okay. And the anterior, previously we were talking more of the posteromedial combination. The anteromedial combination also plays a very, very important role in stability of the fracture. And one has to aim for the anterior anteromedial continuity of the fragment. Next. So what makes a construct very stable? In a DHS, the position of a screw is very important. The amount of comminution plays a very important in your construct. If it's going to be severely comminuted, you try to stabilize it by doing any procedure. And next one is the fracture reduction, bone-to-bone contact. Aim for bone-to-bone contact. Okay. If you are not aiming for bone-to-bone contact, definitely that fixation is going to be very, very weak. It is going to collapse. In the intermediate part, is going to collapse, and sometimes if the comminution is too much, it's going to give way. Okay. And lastly, always add an augmentation to your fixation. Okay. Next. So that is your tip apex distance, which may really plays a very, very important role in the AP and the lateral, which you all know. And the next one is your calcar tip apex distance, which we normally nowadays we talk about it more when you plan for the nailing. Okay, and a lot of the things have been spoken about the 𝐂𝐭 tip apex distance. Okay, so you aim as far as inferior as possible. So here your 𝐂𝐭. Okay. So whenever you try to put your guide wire, you must always have a first amount of resistant, then easy, then resistant, and then easy. Okay. Your first is your cortex, outer cortex, where you reach. Next, it will go smooth inside, and that must be third must be a resistant. That means you are entering into a primary compression trabeculae. That must be there. Okay. And last, once you pierce the primary compression trabeculae and you reach the subchondral bone. So you must have your drill sound itself must tell you all these things are okay, right? Here is where I want my screw to go in. Okay. So if you don't get that one, then definitely your construct is going to fail. If you're not going to follow this 3. Next, the lateral wall thickness. The lateral wall thickness is going to definitely help you in judging whether, if you're all, sometimes you might get a 2-part fracture, but the lateral wall is must be too small, and you might would have planned for a DHS, but when you're trying to put in your screw and your barrel, you see that it becomes a lateral wall fracture. Okay, in that case, you have to add an augment to it. Either once that happens, you must have a standby of a buttressing of the greater trochanter, which you can connect it to a. So how do you judge whether this fracture, this lateral cortex? You normally draw up a line from the tubercle down around 3 centimeter, and you draw a line towards the fracture at 135 degrees. Okay. If your distance is going to be less than 20 mm, that means definitely this lateral cortex is too weak. It is not going to withstand your implant. Okay. Next. So augmentation is very, very important in these type of unstable fractures. There could be an internal augment, or you can use an external augment. The internal augment, nowadays we have the helical blade where it is perforated, where you can inject bone cement once you put into the femoral head. Okay, and hip screws and medial 𝐂𝐭 plate also is available if there is a medial comminution also, which if it is going to be there. External augments are, you can add cerclage wire, tension band wiring. Okay, so these are the external augments. These must be always in standby whenever you're managing this unstable. You must have a clear plan for how am I going to fix this fracture. Okay, so these things must be always available whenever you're planning for your intertrochanteric unstable fracture fixation. Okay, here, doctor, can you just take this X-ray? Previous.
This is a radiograph of matured skeleton showing both hip joints, sir. On the left side, there is a comminuted, sir, intertrochanteric fracture, sir.
Yes, there is a comminuted intertrochanteric fracture. Okay, yes, a traction view will definitely give you a clear view, fracture, but you know that there is a lateral wall is fractured. So it definitely comes under A3. It's an unstable fracture. Okay, and now what will be your method of fixation? Will you go for a DHS for this?
I will see for lateral wall thickness, sir.
No, lateral wall is already fractured. Okay. So, see, lateral wall thickness, you have to look into it only when the lateral wall is intact. Yes. Lateral wall is intact, but then only you will be able to. When the lateral wall is fractured, then normally it comes into A3. Okay, this is A3 unstable fracture. Okay, A3. Right. So PFN. So PFN-A2 will be your ideal implant of choice. Yes. If at all you are planning to do a DHS, you definitely have a trochanteric extension plate also is required for this case. You must have an augmentation. Okay, for this one. Right. Okay. So this was what has been done, a PFN-A2 along with a double tension band wiring for the lateral cortex. Okay. Next. This one.
Sir, again, we can put PFN-A2 with some augmentation.
Yes, you can see that the lateral wall is still fractured over here. Yes. Okay. So once you put it in retraction, you will be able to get a good reduction. You will be able to put a PFN-A2 And for the lateral
Tension
cortex, you can do some augmentation.
Yes.
Okay. Many say that the A2 itself, the nail itself will act as a lateral buttress. You may not require to add any augmentation for the lateral column. Okay. But generally, I normally add some thing that most commonly I use the tension band wiring. I use a double looped tension band wiring for the lateral part. Next. So this is what I was done, but you can see that the fracture has collapsed. But you see the calcar, the nail which is around 15 mm, 15.5 will definitely prevent further sliding of your collapse of your the neck. So for that, you must have a reasonably good amount of neck. That's what I was telling. If you're going to have a very short neck, or if you go small calcar over here, definitely this will not hold good. Okay, it will slip on either in the coronal plane. Okay, it will just slip off and you'll have a cut through. Okay, reasonably good amount of calcar is required for this principle, for the lateral buttress effect of the nail to happen. Okay, and the same thing, this is a very good construct where you wind it around underneath your abductors, underneath your nail, and inside your proximal femur. And it gives a very, very good stable construct where the entire proximal fragment is as a whole. Okay, next. Can you go to this video? I have a small video at how this wiring has been, I normally do it. You can either do it closed, but for the presentation sake, I've just made it a bit wide open. Stop the video. Pause. So, can you come from front? No, from front. First, please. First. Right. Stop, pause. Pause. Okay. So after doing a PFN nailing, you know that's the entry site, and this is where you put your helical blade. And this probably is a stab incision, probably which we used to do a close reduction of your neck. Probably it has been rotated. Okay, we used a Shantzman problem. So you connect these two incisions. Okay, it's initially you don't try to do it open, closed. You open it widely, right? Play. So once you incise your skin and your subcutaneous tissue, what you'll see is your tensia fasciolata. Incise it, you will see your you will see the abductors from there and your vastus lateralis right in front. Right, that's your vastus lateralis, and you'll have to lift this up. Once you see there, and here you see is your gluteus maximus. Okay, so you don't go through the vastus lateralis. You see the junction where the vastus lateralis and the gluteus maximus gets inserted. You incise that, inside the gluteus maximus, erase the gluteus maximus incision. That's very important. Normally, you sometimes get a perforator over there. Be careful. Always use a diathermy in that region, and use the cerclage wire passer underneath your vastus lateralis and bring it out of here. Okay, so this is where this is the most the difficult part of putting the wire. So never try to go through the vastus. Pause it, please. Never go through the vastus. Lift the vastus up, see the bone, pass your cerclage wire underneath your shaft, bring it out where you have made a rent. By erasing the gluteus maximus, you will be able to see it here. Pass your cerclage wire. This is the most important step, difficult step. Once this is done, the other steps are easy. Next one. After doing that, you can wind. And just you can pass your second cerclage. Go ahead. Wire underneath your abductors, and the figure of 8 principle, you can just apply and bring out the wires. After getting the wires out, you have to see to that the proximal wire goes around the nail. So at that time, you need your C-arm. Okay, your C-arm will be very helpful in you can use, this is where you see entry point. You can split open and see your nail there. So you can, these wires also will be somewhere inside. You can see to that the nail is, the wire pass around it. So that now you tighten it, you get a very, very strong construct. Okay, right. So you see that you put a wire, you put an artery forceps or a Homans, so that when you pull and you tighten it, it is around the nail. Okay, not around the GT, and not around the GT or the abductors. Okay, next. Next slide, please. Next slide. Previously, above. Next. All right. So this is an A3 where the lateral cortex also is fractured. So this is what you still want to put a DHS in this case. If you're planning to do it, if you want to put a DHS in this case, what augment you want now additionally?
Some plate we will put extra support on the leg.
So next slide. So once you have your reduction, you know that there is a fracture over here. This is not my slide. I have not used a plate for the distal aspect. I have just taken it from the AVO. They have used a plate in this. This was a very large fragment, so they have used a small plate. Next one. A plate over there, and they have used a trochanteric extension plate. Okay, so whenever there is a GT, whenever there is a lateral column fracture, never use DHS as a implant alone. Either you have to use it along with this, or you will have to change it to a nail. Okay, next. Next. Okay, so this is a trochanteric extension plate, which is now available, where you can just slide it into your DHS plate, and you can add, if you want it to just function as a butters, that is fine. Otherwise, you can add additional screws to it. Next. So apart from the normal, if your calcara is too long, along with the nail, you can add a cerclage wire. So you have to have this augmentation thing. What are all the availability on table whenever you're planning for this unstable intertrochanteric fractures. Next. So this is a severely comminuted fracture where you plan for a nail and additional screws into the proximal fragment, into the proximal neck, will add some more amount of stability, and cerclage wires. Next. This is the same way where you have multiple different angle screws apart from your femoral neck, proximal femoral nail with screws into the neck. You have multiple screws which are available, which will stabilize this comminuted part of the lateral column. Okay. So take care of the lateral column. It's very important. So this now I have not used this at all, but people, they still they use this, where they can attach a side plate for the lateral column within your normal regular PFN nail. Next. And the most important thing, we were all talking about the posteromedial comminution. The anteromedial comminution and anteromedial reduction is also a very, very important step in stabilizing these intertrochanteric fractures. Next. So here is a fracture where you see a double shadow where the calcara has gone inside. Next, please. You get a reduction like this. Normally, we tend to try to put your hand underneath the buttock and lift it and see. Sometimes it is very, very difficult. You might not get that reduction at all. Even how much ever longitudinal traction you give, you will not be able to reduce the fragment. This goes right, it gets driven inside. So percutaneously, you can just put a stab incision, do some amount of finger dissection, put in a shank spin, try to lift it up and try to establish this anteromedial continuity before putting your guide wire. This is very, very important in having a stable fixation. Next. See, get this anteromedial continuity before putting in your wire. You can put the shank spin either temporarily. If you want to put one shank spin above also, temporarily fix it a bit, put your wire a bit more anteriorly so that it doesn't come in your interference of your nail passing. Next. So this is another example where you see it has gone driven inside. How much ever traction you give, you will not be able to achieve that reduction. How much ever pressure you give from your buttocks, you will not be able to raise this fragment. Okay. Or you try to push from the thigh anterior aspect. These are the things which you normally try to do. You try to give some amount of try to push the rather you take a normal shank spin, go in between the fracture and just lift it up. Okay, and you will get this continuity, and you can just fix it with temporarily with wires. Next slide. Okay, next slide. Similar way, you can see this type of rotation of the proximal fragment. It is always better that you do the percutaneous technique where you put a shank spin, or you can even use a lever, okay, to reduce these fragments. Next. Establish this anteromedial continuity in these unstable fractures is very, very important in getting a very, very stable fixation. Bone to bone contact is very important. Okay. The implant is not going to do everything. Okay. You have to give some bone to bone contact and then stabilize the fracture. Next. That's how it has been stabilized. Next. So medial cortex continuity is very, very important. Okay. Even you can use a normal long artery forceps also, that is enough to reduce this. You see that? Before putting in your guide wire, try to bring it as close as possible, lever it so that you put in your guide wire so that you have a very good medial cortical continuity at the end. Next. And the most important thing, you'll just go through this X-ray, get your guide wire correct. Correct in the sense, you will aim in the inferior, in the lateral part, you will plan it in the posterior aspect. In the AP view, you plan it in the inferior aspect. And the most important thing, you must be parallel to both the neck, anterior cortex and the posterior cortex of the neck. So look at this. This is not that parallel to the neck, this guide wire. Okay. You have a good anterior cortex into continuity, but you have put a wire which is supposed to go like this in this direction. It has to come like this. Okay. In that case, it is parallel to the anterior as well as the posterior cortexes like this. Okay. It has to be parallel. Okay. So let us see what happens in this. Next one. It's good. It is good. You're holding the reduction. You put the wire. The wire is not parallel in the lateral view. Next. See, when you put your final tightening of your helical blade and do your final tightening, you lose the reduction. Okay. So this is because the basic principle, as we always say, you must be always perpendicular to the fracture line. You never like your lag principle also. So you must always be parallel. Your wire must be always parallel to your neck. That is another important thing. Otherwise, this is what will happen. It will look good when you're putting a guide wire and everything, all reaming, everything will be fine. But when you put your nail and final do your tightening, you will lose your reduction. Okay. Next. It was so good like this, but finally you lost your reduction. It has gone inside. Next. This might unite, but because it has a lateral buttress effect of the nail, but you have lost your initial reduction, which was too good. This is a delayed presentation of the lateral cortex. This is a late non-union. You can see that the ends, look at this bone and this bone, this was almost osteoporotic. Is it not? It's osteoporotic because of the disuse osteoporosis. You know that this is a non-union. Most of our patients after native treatment, they come here and you can see the neck is in varus. Okay. And in these cases, rather than going and bringing them into the original position, what you can do is you can go and do a simple varus derotation. You can do a valgus osteotomy and fix this. Next slide, please. So we can do a simple valgus osteotomy, a small valgus neck. You can just open up as you do the DHS. you can put in this double angle blade plate which is available and fix the bone. Okay, and this will definitely go in for, once you establish a good angle, neck shaft angle, it's definitely going to go in for a union, because that was in varus. Next.
Sir, it's a A3 type of fracture, sir.
It cannot be A3 because the lateral cortex is intact. Okay.
A2 type.
It's an A2 with
A2.
some amount of medial comminution, isn't it?
Yes.
So probably some amount of postomedial comminution, and the head is in the lateral, it's rotated. Okay, right. Next. A simple PFNA2 with the treatment for this, and probably they will use a shank spin to rotate the proximal femur. Okay, right. Next. So this is what we have switched over from a lateral DHS to an intramedullary implant, which is more stable than the your DHS. Okay, because it has a shorter lever arm, it has a good bending resistance strength. Okay, next. And this is a principle where it acts like a lateral buttressing. Whatever collapse happens, it doesn't collapse, it doesn't allow you to collapse further. But the only thing is, this part of your neck must be a bit longer for this principle to act. If it is going to be short neck, it is not going to act. Okay, so it has to be a relatively longer part of your neck where this buttress effect of your intramedullary nail will act. Okay, if it is going to be a plate, it will collapse till here. Okay, till it reaches your lateral aspect. Okay, right. Next.
Again, A2 type, sir.
The lateral cortex is fractured. When the lateral cortex is fractured, it comes into
A3 type.
A3. Okay. Okay. Next. So that is again a PFN. It was not a good screw and the good length, but still. Can I have the next slide? It collapsed, but still the nail is going to act like a buttress over there. It is not going to further collapse further. Okay, you just allow some amount of protective weight bearing in this patient. This fracture will definitely go in for union. But the most important thing is establish this anterior continuity of the fragment. Okay, right. Next. So always have an augmentation. Okay, so this is the next one. In-text augmentation, that is either an internal as well as an external augmentation. Devices must be available whenever you are treating this unstable intertrochanteric fractures. Next. Next slide. Okay, and the final tips, this is from the AAOS. Avoid fracture distraction when nailing. When you are talking for the intertrochanteric fracture, when nailing, lock the nail distally. Use the tip of the trochanter and the center of the head to assess the varus. Do not use a hammer to see the nail. Always try to drive it inside. Adequately ream. Do not ream an unreduced fracture. Always reduce and then fracture the nail, ream it and nail it. Okay. Start slightly medial. And another most important thing is the medial entry, the entry point of the nail. The entry point of the nail is not at the tip of the greater trochanter. It is slightly medial. Okay, so slightly medial. Beware of anterior bow of the femoral shaft when you're trying to plan for this old age. When you're planning for a longer nail, beware of the anterior. Know that unstable intertrochanteric fractures, patterns, and then nail them. So if there is no lateral wall, there is no DHS. Don't plan for a DHS but if you still want to go and do a DHS for that patient, what you will do?
Trochanteric plate we can put, sir, as a augmentation.
Okay, you must have a trochanteric extension plate. Okay, and always aim for the tip apex distance to be perfect, and placement of your screw also. Thank you.
Thank you very much, sir. That was very informative and very elaborative on intertrochanteric fractures. The next session will be done by Dr. K. Harikrishna Reddy, sir, Professor of Orthopaedics, Narayana Medical College, on complex distal femoral fractures, choice of implants.
Good morning to all of you. The topic is complex distal femoral fractures, choice of implants. So we know that distal femur fractures are very few. It is all femoral fractures account for 1%, and distal femoral fractures account for 3 to 6% of all the femoral fractures. And moreover, it is very challenging to do the distal femoral fractures. Next slide. So the distal femur fractures include the fractures of the supracondylar region and intercondylar region of the distal femur. And to avoid the high morbidity and mortality correlating with this fracture, it requires a prompt diagnosis and treatment. So the goals of the treatment is AVO principles, that is anatomic reduction, articular restoration, restoration of the limb alignment, length, and rotational alignment also. Despite there are a lot of improvements in the implant design, management of distal femoral fractures are always a challenge, because when it involves the articular surface, the patient will be having comorbidities. That is, post-traumatic arthritis is very common in this. So the patient will once again have to go for a revision surgery. So it is very challenging. And moreover, the fractures are all comminuted intra-articular and they involve osteoporotic bone, making the fixation challenge to achieve. Especially in the geriatric population, if you happen to see, the comorbidities are high and the impact of the therapeutic options are very, very minimal. So it is very difficult to manage distal femur fractures until you have a very good exposure. Next slide. So as I told you, of all the fractures in the human body, 1% of the fractures only occur to the femur. Among that 1% of the fractures, only 3 to 6% are pertaining to the distal femur fractures. So if you happen to see, adult distal femoral fractures present in the bimodal distribution, that is the young age group as well as the old age group. In the young age group, it is mainly because of high trauma, that is road traffic accidents. These are the major common causes. In elderly patients, even a fall on ground level falls also will cause distal femoral fractures because they are very osteoporotic. Next slide. Next slide. So elderly persons often present with the significant comorbidities impacting their operability, recovery, and survival. You know, as I told you, the geriatric populations, they have many comorbid conditions like CVA, previous CVAs, and different types of diabetes. All those things will be there. So it is very challenging to operate in a highly, very aged patients. In the pediatric population, the problem will arise if the intra-articular surface is not reduced properly. They may have post-traumatic arthritis in the future. So that is also an important thing. As the population ages, the treatment of these complex fractures are correlated with poor outcomes. Next. So this is the classification. First, I would like to give you the classification and what are the implants that are available for the distal femur fractures and how to treat them. So this is classification is 3-3, A1, A2, and A3. 3 refers to the femur. And next slide, ma. 3, the other 3 refers to the site of the femur. A is nothing but the extra-articular fractures. B is partial articular fractures. 3 is complex articular fractures. So if you happen to see here, the first one is 3-3-A1. That is a simple fracture that is not involving the articular fracture. That's not involving the articular surface. The second 3-3-A2 is metaphyseal wedge or a fragmented wedge. You can see the metaphyseal wedge over there and a fragmented wedge in the second figure. That is 3-3-A2. And 3-3-A3 is nothing but metaphyseal complex fractures not involving the articular surface. This is 3-3 B1, B2, and B3. B refers to the partial articular fracture. It is not a complete, it is a partial articular fracture. If you happen to see here, it is B1 is nothing but lateral condyle fracture, B2 is medial condyle fracture, and B3 is frontal fracture. In the B3 session, you have this Hoffa's fracture also. Next slide. So this is 3, C1, C2, and C3. C refers to the complex articular fractures. If you happen to see here, C1 is articular simple and metaphyseal simple. 3, C2 is articular simple and metaphyseal multifragmentary. 3, C3 is articular multifragmentary. Okay, it involves both the articular surface as well as the metaphyseal surface. That is the most complex surgery to be managed. That is 3, C3 is very difficult to be managed. Next slide. So first, I would like you to know the screws and the implant. Before going for the implants, you should be able to know about the screws, the sizes of different sizes of screws, and the taps and the core and the pitch, everything you're supposed to know. 1 second, go to this next slide. Next slide, show me one screw. You need one screw. Yeah. You know, this one is a Richard screw. This one is the 6.5 mm locking canceller screw. So what we refer is the pitch. The pitch is nothing but the distance between the threads. This is the pitch. Okay. And the distance from the tip, that this is called as the crest of the thread, and this is the root of the thread. From the from the crest of the thread to the crest of the thread, it is called as the major diameter. And from the root of the thread to the root of the thread, it is called as the minor diameter. So from the thread to thread, usually we call it as the size of the screw, that is 3.5 mm or 4.5 mm. Okay. And if you happen to see the drill bit which we use for this type of screws, measure the root of the screw to the root of the screw. Whatever the measurement is, it is just 10% more the drill bit is used. Okay. And moreover, we have to know this is the tip of the screw. This is the shaft of the screw, neck and head of the screw. These are the questions that they might be asking you in your exam. So you're supposed to be well versed. Go to the previous slides. Yeah, this one. So here, 4.5 mm screws. The pitch is 1.7 millimeters. The core is 3 millimeters. Core is nothing but the minimum diameter, the distance between the root of the screw on one side and the root of the screw on the other side. The drill bit is 3.2 mm. I told you this is the minor diameter. In the diameter, it is just 10%. If I happen to look at all the core on the drill bit, it will not be more than 10%. That you should be having an idea. And the tap is always equal to the screws. If you use for a 3.5 mm screw, if you happen to use a tap of 4.5 mm, what happens? The screw will be loose. The chances for the implant failure and the screw backing out will be more. So these are the screws that which we usually use. So 4.5 mm system, 2.5, 2.7, 2 mm and 1.5. Apart from this, for locking screws, there are different types, which we will show you in the later slides. So in the cancellous, we usually use 6.5 mm and 4 mm. So the core for the 6.5 mm cancellous screw is 3 mm and the drill bit is 3.2 mm. The tap, as I told you previously, it will be the same as this system. It will be the same for tap also. So tap should not be more than your locking system. That you should keep in your mind. Next. So different types of implants that which we use for distal femoral fractures. First is dynamic condylar screw, because this was the first screws that which we used for distal femoral fractures previously. Next slide. So in that you have that Richard screw, you have that cortical screw, 5 mm locking screw, and then 6.5 mm locking screw. So not all the DCS will be having similar type. It may vary. you're supposed to know the slots. That is quite important. In that Richard screw, if you happen to see, the distance between the crest of the thread to the crest of the thread is around 12.5 millimeters. And the shank is 8.5 millimeters. The length may vary 5 millimeters apart. Okay, the length of the screw may vary 5 millimeters apart. So this is the slot that where we use for the we use the Richard screw. And this is the locking screw, that is 6.5 mm locking screw that we use. And then you have the locking screw. Locking screw is about 5 millimeters and 4.5 millimeters cortical screws. So the tab that which we had to use for 4.5 mm cortical screw is 4.5 millimeter tab. It's similarly for locking screw, it is 5 millimeter tab. Here 6.5 millimeter tab. We had to use all those things. Okay, we can use 4.5 mm. It's not 6.5 mm, 4.5 mm. Little bit we can use for that. Next slide. So this is one of the X-rays that where a DCS has been put. Next. So this is the distal femoral buttress plate. For intra-articular fractures, we use distal femoral buttress plate. Next slide. So in this system, you have a 7.3 locking cantilevered screw for this slot. For this slot, we use it. As I told you, not all the buttress plates and the locking plates will have similar type. The system might vary. You're supposed to be thorough with the system before operating. And 5 mm locking cantilevered screws are used. There you have the 5 mm locking screws and 4.5 cortical screws where we had to use. And we have specifically mentioned where are the slots, where are the screws that has to be put. Next slide. So this is an example of a buttress locking plate. You can buttress bicondylar plate. This is next slide. So this is the distal femoral locking compression plate, which most of us use. It's quite common nowadays. Next slide. So in this, you have 5 mm locking screw, 4.5 mm cortical screw, and 5 mm locking canceller screws. These are the screws that are used for this implant. Next. This is an example where we have used a locking compression plate, distal femoral locking compression plate. Next slide. So this is the distal femoral nail. So this distal femoral nail for all the metaphyseal fractures, mostly nowadays we use this distal femoral nail. We usually try to avoid for intra-articular fractures because we will not be able to maintain the articular surface while inserting this implant. Next slide. So this is an example of a distal femoral nail. So these are the cortical screws. I told you the pitch, core, neck, tip, and all the major diameters and the minor diameters of the screws. Next. So these are the 6.5 mm canceller screws. The canceller screws will be partially threaded and fully threaded. Partially threaded we usually use when we need to have a log effect, and fully threaded we use it when it's a complete fracture. Next. So these are the various types of locking screws. Next. Next. So this is fracture. I would like one of our postgraduates to come over here, and I would like you to tell which implant of choice would you like to use. Tino, would you like to come? Take him. Read the X-ray.
Sir, there is a distal femoral fracture, sir. So I would like to go with, as there is no intra-articular extension, I would like to go with distal femoral nail, sir.
Distal, any other choice?
Distal femoral lock, buttress plate also we can go, sir, but
you can use a buttress plate
plate
also, but DFN is the choice. Why do you think DFN is the choice?
as there is no any Intractor extension, sir.
That is one point. The other point is it a load bearing or is it a load sharing?
Load sharing.
So that is the important aspect. So this one you can go ahead because the working length also will be good if you put a long nail and it will be good. Okay, we can put even condylar buttress, but that has a different structure and that has weight sharing effect, weight bearing effect. So it is better to use what you have said. Okay, next, thank you. Please go ahead. Next slide. Next slide. So for the C X-ray, anyone from NRI, would you like to come and say? Okay, Vinay, please come. Under what classification does it come?
This is a unicondylar fracture, sir. 33B1, sir.
What would you like to do for this?
Sir, I would like to do distal femur locking compression plates.
That is one choice. The other one?
Distal femur lateral buttress plates, sir.
These are the two choices that which you can go. Why can't you go for a nail?
So, intra-articular extension is present, sir.
What happens in the intra-articular extension?
Entry point will be difficult and there will be a shattering also, sir.
That is the correct thing. If you happen to put a DFN in this plate, you can expect shattering of the distal femur. Okay. Okay. Thank you.
Thanks.
Next slide. So you can see type B. Sukanya, where is Sukanya? Please tell me the classification, ma.
So C3, sir.
Good, very good. What would you like to do for this case? Would you like to do this case or refer to someone else? No, you have to do. What is your choice?
We can.
See, the bone is also very osteoporotic. Have you noticed that? So what would you like to do for this?
Temporary stabilization.
That is one option, but if you want to do a definitive fixation, what would you like to do? The surgery requires a very long time. You should open up the joint space very well. You should arrange all the articular fragments properly and put a bicondylar buttress plate can be used. And suppose if the patient wants to go for a major surgery like replacements, what would you like to do? Even that is also a choice. But the thing is, usually if you wait till the fracture consolidates, go for a replacement, then that will be a good choice. Okay, please go. Next slide. So this is one of the cases that is done in our institute. A 50-year-old male patient who has come to our hospital with an RTA. Last year he has come, and for him we operated. Please show me the X-rays, Riaz. So the patient had fracture of the distal femur. The next X-ray, and middle and distal 1/3 tibial fracture also on the same side. So on a single sitting, what we have done is, next slide, Riaz. We have fixed the distal femur, metaphyseal distal femur fracture with a buttress plate, locking compression plate, and then we have fixed the tibia also. Actually, the fixation was good, and we had done the dynamization also for this patient. And we told the patient not to weight bear because it was on the same side. But unfortunately, the patient, he weight bared it. So again, when he came up for the follow-up, he presented with, next slide, he presented with this type of X-ray. So the implant got bent over there. So what would be your choice? What would you like to do? Bhargavi, what would you like to do? Why can't you just remove the implant and go ahead with the surgery? We advised the patient to go ahead with the next surgery immediately, but the patient was not willing. So we had to convince the patient, and the patient, he presented to us after a few months, and then he presented with, next slide, with this X-ray. Once the implant got broke and patient had pain, only then he has come for surgery. So one thing was, while operating this also, we thought it was only metaphyseal fracture, but the fracture was extending to the intra-articular region also. So we had no other choice. Even though if it is intra-articular, we thought of holding the intrafragmentary with a patellar clamp, and then we went for DFN. And we luckily there was no splinter, and we were able to do it. Next slide. So we took it out, we broke it, and we brought to some sort of alignment. We put a bone graft, and then we fixed it to the DFN. Only problem was the length of the DFN was a little bit more. That was because we had a problem with the CM at that particular time, and we had to do it blindly. So that was the reason. But luckily the patient has full flexion and extension. There was no pain, anterior knee pain, it was not there. So in that case, we were saved. So even implants of choice also sometimes due to our negligence or due to the patient's early weight bearing also, we might face this type of fractures, and the resurgeries we had to do it. So do you have any doubts regarding these implants? Okay then, thank you very much.
Thank you very much, sir. The next talk will be Dr. Natarajan, sir, Professor and HOD of the Department of Orthopaedics, Savita Medical College, on tibial plateau fractures.
Good morning, all. Of course, good afternoon. So I thank Dr. Biju and his team for organizing this wonderful CME about complex lower limb trauma. And I have been here for many times, and now to give a talk on proximal tibial fractures. So, and the CME topic is for a complex lower limb trauma. And the tibia fractures, proximal tibia fractures, most of the times is complex. So I come from Chennai, Savita Medical College. I work here for past 14 years. So we come across a wide variety of trauma, and we got a experience by burning our fingers in many cases. So today we will learn from our experience not to make some mistakes. Next. So we always tell it's mainly due to high energy trauma. So consider all the proximal tibial fractures as a soft tissue injury associated with fractures. So never think that as a fractures like diaphysis, femur shaft fracture, or tibial shaft fractures, or forearm fractures. Always consider them as a soft tissue injuries associated with fractures. So next. So you all know the knee, and it's mainly a weight bearing component. So the proximal femur articulates with the distal tibia, and distal tibia transmits the weight. It is a place where it receives the weight. So unlike in the distal femur fractures where the malunion is poorly tolerated, and of course we need to put the tibia into proper alignment to prevent complications, but even some amount of malreduction, we have seen that the function of the patient is good. Next. So lateral tibial plateau is a convex, and medial tibial plateau bears most of the weight. It is concave. Next. There is a posterior tibial slope and a varus of 3 degrees. Next. So ligaments are there. So as I told you, fractures will be associated with some soft tissue injuries, including ligaments. Next. So what we are worried is the vessels and nerves. They are very close proximity to each other. Next. So more load is borne through the medial tibial condyle. Next. So how they got injured? So the weight getting transmitted through the distal tibia many a times and then associated with the varus or valgus loading. So bicondylar fractures also occurs because of if there is no varus valgus and if the force transmits directly through the medial tibia. Next slide. Next. So if the force is transmitted directly from down to up, so then the condyles will, both of them will break. And if there is a varus thrust and so the medial condyle will bear the implant, it will fear the fracture and the lateral side will have a ligamentous injury. Next. So the common fracture patterns, as you all might have seen, lateral tibial fractures are more common because of the varus load. And bicondylar comes next and medial tibial plateau occurs in a few people. So lateral tibial plateau might split or they may have a split depression component or it can be a bicondylar fractures associated with the shaft diaphysis. So all are inclusive of the tibial plateau fractures and along with the ligament avulsion fractures. Next. So we should have some classification which we follow so that people can understand and finalize the treatment plan. You all know about these classifications. What we commonly use as Schatzker and 3-column classification now. Next. So you all know Schatzker type 1 is a lateral plateau split fracture and type 2 is a split with a depression. Depression we mean that the articular cartilage has gone down because of the axial loading. And type 3 is only a depression and type 4 is a medial condyle fracture. Type 5 is a bicondylar fracture. Type 6 is associated with metaphyseal diaphyseal dissociation. Next. So this is a classification we now rely more based upon the CT. So it was done by, first proposed by Leo. So next. So where we classify the proximal tibia as seen from above is an anteromedial, anterolateral, posteromedial, posterolateral. And then we have anterior tibial spine avulsion and posterior tibial spine and the anterior tuberosity, tibial tuberosity. So whatever column is gone, we have to reconstruct. That is the idea. So we have to buttress and reconstruct so that all the things have been put together and then they will give a good proximal tibial construct. Next. So patients, most of them, they will have polytrauma and they may present with an isolated proximal tibia fractures. So usually associated with the high velocity. They will have an associated bruises. They will have an associated open wounds. They may have swelling of the knee because of the hemarthrosis which are seen. So the tibial plateau is an intra-articular fracture. So the blood will collect inside and the knee will be swollen. So they will have severe pain. Next. So a history may usually high energy, sometimes in case of elderly low energy fractures. Next. So look for open injury, associated soft tissues and palpate for intra-compartmental pressure. Next. So and always look for stretch pain. So the proximal tibial fractures, especially type 4, 5 and 6, they are high energy problems and they have an associated compartmental syndrome. The intra-compartmental pressure both in the posterior compartment and in the anterior compartments, they will get elevated. And please look for stretch pain, which we feel is the most important thing to identify and to make a decision regarding whether to do a fasciotomy or not. So they say about measuring the ankle brachial index, but it's very difficult to measure the pressures. So we generally don't follow these things because in a case of pressure limb, we cannot measure the pressure using a BP cuff. Next. Assess for the nerves also, common peroneal nerve, tibial nerve. And then once there is no compartment pressure or anything, so nothing, once the patient is stable, shift for an X-ray, AP and lateral view. You assess for the component like intra-articular, what condyles have been broken and what type of Schatzker classification follows. What about the displacement and what about the bone quality and whether the joint is dislocated or not also you please assess. So there might be a fracture of the tibia along with the joint dislocation might occur. Next. So sometimes we may miss the small posteromedial fracture lines. In a good quality X-ray, you can easily identify them. Then abnormal tibial slope. Normally it should be sloped like this. Now it has gone up. Next. So in high tibial fractures or high energy injuries, so you get an X-ray done, and once you think that the skin condition is poor, so they are, as you know, that proximal tibial fractures, the skin will go for a fracture blisters, compartment syndrome. Once you go on and fix the fractures immediately, sometimes it may lead to infection or it may lead to necrosis of the proximal skin and exposing the implant, and that makes our life very difficult for us and also for our patients. So you have to delay the fixation, permanent fixation, by doing a temporary external fixator. So you can, that is knee spanning external fixator you have to do, and then you can do a CT scan, classify them, and then you plan and fix the fractures. Next. So knee spanning external fixators we commonly use for type 4 and 5, type 5 and 6, and sometimes also for type 4 also. So in open tibial fractures, we can do it. And when there is a high energy injury where the associated soft tissue injuries are very common, you can do it. And whenever there is a suspected compartment syndrome, you do along with them fasciotomy. And if there is an associated vascular injury, you do a X-fix. Next. So various type of external fixators can be used. Commonly used are biplanar. You put the pins in the femur laterally and you put the pins in the tibia and anteriorly, and then you connect with the rods, and then you reduce the fracture, and then you can connect with the using tube-to-tube connectors. So this is what we used commonly. And now we switch over to the single thing where we put the pins anteriorly into the thigh, just outside the joint, that is about 4 finger breadth above the upper border of patella. So you can put through the quadriceps pins and then uniplanar fixator, and we can use a translucent rod so that you can have a good reduction and good stability, and we can use it for during our permanent fixation, and plan the pins always in mind with the definitive fixation. So don't put them very close to the fracture site where you will have to put some plates, and convert them as soon as the skin condition settles down. So once the wrinkles appear, then probably we have to do surgery. Don't delay too much. So usually we do it in about within 10 days. And sometimes if you have to do after 14 days, the chances of infection becomes high. Next. So we can do conservative treatment for minimally displaced or undisplaced tibial plateau fractures, or in an elderly or those patients who don't have fitness to do surgery, we can put in a plaster or we can put in a knee immobilizer, and once the fracture consolidates, we can make them mobile. So now more and more people operate when there is a depression of more than 5 millimeter or condylar widening more than 5 millimeter, or varus valgus instability is there, and in bicondylar fractures, we need to operate. Next. So whenever we plan for surgery, you remember, so we have to do reduction should be accurate because it is an intra-articular fracture. and then you have to provide a stable fixation to make them mobile. And please preserve the blood supply, don't denude it, so that this bone is not a mechanical thing. So it has got biology, and blood supply is important for healing. Next. So permanent fixation we can do for type 1, 2, and 3 as soon as the patient comes, and if there is not much of a swelling and skin condition is good, you can do a primary internal fixation early. And type 4 and 5, you need to do a staged fixation. So once the patient comes after injury within 1 hour or 2 hours, and you see the skin condition looking good, don't promise them we will do a internal fixation immediately. Say by the time you arrange the implant, say 6 hours or 8 hours. So once you take the patient into the theater and open the POP or whatever splints you have applied, you might be surprised to see a compartment which is developing inside, and you will see the skins having fracture blisters and all. So always try to do the high energy injuries as a staged thing. So first you put in an external fixator, and then once the skin condition settles, usually in about say 7 to 10 days time, you convert them into a permanent fixation. So in type 1, so this is a split fracture. So proximal fibula is intact, can go ahead and do with multiple cancellous screw fixations. So if the fibula is also broken, probably we have to buttress them. And now most people, they add plate for even type 1 fractures with intact fibula. Can do it, no harm in it. Next. In type 2, so where there is a split and depression, so you have to elevate the fragment, and then you have to do a buttress plating. So you have to reduce the fracture, and then you have to fix. Next. So in type 3 fractures, the pure depression, so you can elevate it and you can use a raft fixation. Next. So in type 4 fractures, where there is a medial condyle fracture, so we have done an MRI also with the ACL injury is there. Next, you can go for a buttress plating and you can do a reconstruction, usually delayed. Next. In type 5 bicondylar fractures, so again we have to do a external fixation initially. Next, then you can go for a bicolumn plating. So posteromedial plate has been applied and anterolateral plate has been applied. Next. So in type 6, along with the proximal diaphysis dissociation or proximal diaphyseal fracture, do a X-fix first. Once the skin condition gets better, next. So you can go and do the columns, whichever is broken. You can use whatever number of plates. So here we have used 3 plates for posteromedial, medial, and lateral plates. So we can use an external fixator as a permanent fixation also, either as an Ilizarov construct or as a hybrid fixator. Ilizarov fixators can be used in severe open fractures with marked contamination, or in cases where internal fixation you think is not possible. Next. So you can go with the three ring construct, and then initially it was stabilized with external knee spanning external fixator, then converted into a Ilizarov fixator. And at the end of 4 months, you can remove it. So go back. Okay, next. So these are the things which you keep in mind whenever you come across a tibial plateau fracture. So how to do it? So you position the patient. Either you can do it in a fracture table, which we don't do nowadays, because even though it gives an access to the C-arm all the times, we cannot manipulate much. So generally we do it in a radiolucent to a table. And if there is only lateral side is gone, like in a type 1, 2, or 3, you can keep a bolster below the iliac crest. You can keep the leg internally rotated so that you can have good images. And then we use a bolster or a folded pillow for proximal tibia fractures so that we can expose them nicely. Generally, we don't use a tourniquet. So, but people can use tourniquet, especially if you want to do a submeniscal arthrotomy and want to view it. Most of the times we can get away without using tourniquet. And then you can choose whatever approach you want to do depending upon the fracture pattern, either lateral or medial, or if you want to do a bicondylar fixation for fractures involving the anterior aspect of the tibia, say anteromedial and anterolateral column is gone, you can open through anterior midline approach. You can take the soft tissue sleeves on either side, and then you can fix with both the sides with plates. Posteromedial, you can use for posteromedial fractures, tibial plateau fractures for buttressing. So next is you can use a posterolateral approach. So there are various modifications. You can either do a fibular osteotomy, or you can go both for anterolateral fixation in a single incision, the modified Frosch. So you give an opening and then you approach the anterolateral here and you go through the posterolateral here between the lateral head of gastrocnemius, and then you can see the popliteus tendon here, and then you preserve the common peroneal nerve. And anteriorly, you can take out the tibialis anterior and do both the column fixation through the same approach. So this is the anterior part and this is the posterior part. Posterior window you can do. Next. Go back. Go back. So also you can do a minimally invasive plate osteosynthesis. You can open the proximal part. You can slide in the plate and you can fix with the distal part, especially in the lateral side. And if you want to use a long medial plate also, you can use this technique. Posteromedial, usually we don't do MIPO. Posterolateral, definitely we don't do MIPO. So you can go for medial or lateral plates. Most of the times for lateral plates, you can go for a minimally invasive techniques to overcome the soft tissue problems. So you have to elevate the articular fragments. Either you can go through the fracture site or in a type 2 or type 2 especially. There is a lateral split depression fracture. So open book injury, you can preserve the soft tissue attachments of the lateral tibial plateau and then go through the fracture site, open the fracture site, see the depressed articular fragments, elevate them, and then compress the fracture condyles. And then you can go ahead with the fixation. Or it can be type 2 or 3. You can use through a cortical window from the opposite side. You make a cortical window of around 1 centimeter into 2 centimeters. Put in blunt elevators or there are special instruments designed for it to elevate it. Don't use sharp instruments. And if you don't have anything, you can use a 4.5 screwdriver also. But mostly you use a punch. So punch will not break the fragment. It will elevate it wholly. Make a cortical window a little bit distal. Don't go very proximal so that you will get the correct angle. Plan it for a lateral tibial plateau. Go it in the medial surface. You make a window and then you punch in. You introduce the punch and elevate it. And then whether how much elevation is done, you can assess through C-arm. In this, you have to keep the knee extended. Then only you can assess it properly. And then keep the knee in extension. See the C-arm both in AP view and in the lateral view. And you can do a provisional fixation with the K-wire before rotating the limb to see the lateral view. So, or you can do a submeniscal arthrotomy to see the elevation. Next slide. So, submeniscal arthrotomy is nothing but you cut the capsule closer to the lateral tibial plateau So for that to do, you have to know the fracture pattern and you feel the lateral tibial plateau. And then you can use some needles to find out where the joint space is. Then you can cut the capsule close to the tibial side, not towards the femur side. And then once you cut it, and you can use a 2-0 Ethibond sutures. Number 2 or mostly we use Ethibond sutures, or you can use Prolene also. And then you can elevate the meniscus along with the proximal capsule, and you distract the tibia. You can use either a femoral distractor or you can do manual distraction. And then once you elevate then thing, you can see nicely how much elevation we have done through the submeniscal arthrotomy. Next. Oh, previous slide. So, or you can do also arthroscopy assisted. You can do a scope and see whether the tibial condyles are being elevated well or not. We have used it, found to be more cumbersome, so more time taking, doesn't add to the value, and we no more use it. So, and then you compress the condyles, whatever widening has happened, you compress them using a pointed clamps. So bone quality will be usually good. You compress them. So you just many people I have seen with the post-operative X-rays. So they will have good articular elevation, but not a good alignment. So the tibia will be still subluxed, so leading to post-op problems. So compress the condyles using a pointed clamps, and then you can provisionally fix it with multiple K wires. And K wire should be planned that it doesn't involve in the permanent plate fixation. So you have to plan it, and then you do a plate fixation. So how will you choose the implant? What implants can be used? So you can take up screws alone, as I told you, in type 1 fractures or in avulsion fractures or in tibial tuberosity. If it has come up, then you can put in screws. So, and in type 1 fractures with intact fibula, and the plates can be used for the other fractures. You can use it in buttress mode for stable fractures and for a good quality bone. You can use either a T buttress plate or a L buttress plate, or even 1/3 tubular plate can be used in a buttress mode. Or compression plates, we rarely use them, but still we can use it. And locking plates are nowadays commonly used. So locking plates, they will make the angle, fixed angle once the screws are inserted and locked, and they prevent collapse. So they are the favorites now. You can use a lateral plate or a raft plate. Raft plate is where there is more progression into the posterior part, and where there is more comminution. You can use multiple screws, small screws just below the articular fragment, and you can use this plate. Medial plate can be used. Anteromedial type of fracture, posteromedial plate, locking plate we can use for posterior thing. There is one more implant now has come as a variable angle. So variable angle means in the same locking you can use multiple, say around 30 degree you can have a ply, and we can use it for cases where you want to say where there is a good bone, you can take a good purchase. So in very severely comminuted metaphyseal areas, you can use a variable angle locking plate. External fixators can be used. So screw length has to be properly planned. So if you want to use a bicolumn plate, if you use a long screws, then it will hinder the medial plate fixation. So use proper screw lengths, and depending upon the plan where you want to fix it, have proper screw length. Plate length also has to be correctly planned. You cannot use the same length on both the medial and lateral side. Generally, we go for a long lateral plate and a small medial plate. Sometimes in more medial fractures, we may use a long medial plate and short lateral plate. Screw hole ratio, you don't put a screws in all the holes. Whenever you use a buttress type, you span the screws, and you put some 3 or 4 screws in the distal part. And then once you, and another thing is plate positioning, where you have to place the plate. So previously, when we were postgraduates, we used to fix all the plates subperiosteally. Now in a MIPO concept, so you have to preserve the vascularity. You can put the plates in submuscular region. You can slide the plates into the submuscular region and you can fix it. And then once you fix with the plates, you have to assess the stability. That's where the thing comes. So whether the fixation is stable or not. And once the fixation is stable, whether the knee is stable or not. What are the associated ligaments which are gone? You assess them by putting through a range of movement in that table itself, flexion, extension, and then you can assess clinically, and then you can assess fluoroscopically. And once when you are convinced, then you can go ahead. Next step. So you do varus valgus anterior and posterior stability testing intraoperatively. Previous one. So, and the most important thing is once you fix the proximal tibial plateau, check for the distal vascularity, not only in the intra-op period or in the post-op period, and also check during the first day and second day. So sometimes you may develop compartment syndrome in the post-operative period. So closure. So if you have done things properly, usually the closure will not be a problem. But if the timing is bad, and then if the skin is swollen and the muscle is swollen, we will be faced with these problems, closure problems. So don't put tight sutures and try to cover the plates if they are going in for tension. So you can leave some amount of gap. So please don't close them in tension. If you are having problem, you can even leave it open and then whatever without tension you can, because tension sutures actually increases more pressure and leads to more ischemia to the skin flaps and more death of the skin flaps, and definitely will need a plastic surgery later on. Plates will be exposed, infections are common. So we'll end up with more problems than solutions. So try to avoid sutures in very much tension. You can leave some gap, or if you are very much in doubt, you can just leave it open and do dressings, and then take it up for a second look in say another 4 or 5 days time. So don't do dressings in between. Put in offsite also. You can do dressing, and sometimes vac also will help. But we have done sometimes plate exposed also. We just don't put sutures. We just put a compression dressing over it. They all do well only. So can go in for a hybrid X-fix instead of a Elizero also. So proximally you use a ring, and then you can distally you can use a uniplanar rods. Next. Open fracture came. So skin was bad. So proximal fragment was little jetted out. So you can fix it with the screw. And then we used a hybrid X-fix. Next. Patient went on to heal well, and implants were removed at the end of 4 months. Next. Next. So, of course, we have our own bunch of complications dealing with proximal tibial plateau fractures. The dreaded one is an infection. So probably poor timing of surgery, or poor soft tissue cover, or in a poor, in an immunocompromised patient, more soft tissue stripping, all might lead to infection. So please identify the bug. So one way of treating infection is to identify it early. So generally we give only 3 doses of antibiotic, 1 pre-op and 1 post-op, and next day morning we give one dose of antibiotic. Then you don't give. So identify the infection early and identify the bug early. That is the key to treat infection. So you will usually identify such type of infection, if at all, if the patient is going for infection, in about 5 or 6 days time. You will see the collection coming and probably a purulent discharge. So send it for culture, get the bug, and then go for plan for a debridement. So and wash, wound wash. So take the culture, give a sensitive antibiotic for about say 6 weeks, and then you can also give the antibiotic Next. So you can give the antibiotic mixed with biocomposites like stimulant. You can keep it in the during your wound wash. So here it was staph aureus. So we mixed it with vancomycin and kept it. Next. So went on to heal well. Next slide. So we took out the implant in a period of about 1.5 years. Next slide. So they can be easily managed provided you identify them early. So you don't give them for 5 to 7 days of antibiotic or 10 days of antibiotic. Delay the infection. So then they will be very difficult to manage. These things, they get away without any plastic procedure, without any additional procedures. The other complications include compartment syndrome. We have to do fasciotomy. Whenever in doubt, you please do fasciotomy along with the external fixator. Knee spanning X-fix. Vascular injuries. We have come across anterior tibial artery injury, posterior tibial artery injury. So we have reported also in one journal that vascular injuries, and we have done anastomosis also for anterior tibial artery along with the vascular surgeon. Fixation, and then you do a vascular repair. Don't confuse DVT with compartment syndrome. So common peroneal nerve injury is common. So they may have foot drop. So you can go in for a wait. Usually it recovers in 3 months to 6 months time. If it doesn't recover, you can go for a tendon transfer. So they may go for associated ligamentous injury, may have knee instability. This is the case with the medial fracture with the posteromedial plating done. They had a MCL injury, can go in for a late reconstruction. Whenever there is an associated ligament injury and a fracture, deal with the fracture first, bone first, followed by soft tissues. Next. So we have done a reconstruction of the MCL. Patient went on to have good function. Next. They may go for a stiffness. So especially in those patients who tolerate pain poorly, they don't undergo rehabilitation well in the immediate post-op period. You can give pain blocks or you can give epidural blocks or pain management so that we can make the patient mobile. And second thing which is common is if you fix it with say less optimal fixation, probably we will delay the mobilization that might lead to stiffness. So don't do manipulation like in a shoulder because it is fraught with complications. It may lead on to fracture of the bone. So plan with the arthroscopic assisted arthrolysis. Next slide. Can take out the adhesions. Usually we will have good results. Next. Malunion, of course, that's what we want to avoid. So if there is malunion, then we have to go in for an osteotomy and refixation. Next slide. So other complications include RSD, late collapse and secondary osteoarthritis knee. Quite uncommon in our experience. So if at all if they develop an osteoarthritis, then probably we have to do a knee replacement. Next. So to conclude, make a correct diagnosis. So associated injuries, please identify them early and intervene at the correct time. Next slide. So you span the knee, then do a CT, and then you plan, and do a definitive fixation, and then address the ligamentous injury. So I think
Thank you very much, sir. The tips and tricks you have given will be very helpful in our future endeavors, sir. Thank you very much, sir. In the next session, ankle fractures and calcaneal fractures will be commenced after lunch. And in the end, we'll be awarding certificates. At the time of certificates, you have to fill a feedback form about the CME. Thank you. You can go with the lunch.
Smaller.
మిగతా ప్లీజ్.
Good afternoon, everyone. I am Dr. 𝐂𝐨𝐽𝐵. Today I am going to discuss about ankle fractures. The ankle fractures is what I feel most difficult during from my post-graduation time onwards, because the classification itself is almost taken for me 6 to 7 months to understand that. Yeah, now I'm going to tell about brief introduction of ankle fractures. Yes, ground. See, ankle. Okay, coming to the next mundu. Yeah. See, coming to ankle fractures are the most common injuries, and management of these fractures depends upon careful identification of extents of bony injury as well as soft tissues and ligamentous damage. Next slide. See, coming to most important thing in ankle fracture is everybody should know about the anatomy of the ankle. See, ankle is usually formed by 3 bones: tibia, fibula, and thallus. See, again, is thallus is articulate superior to tibial profundo, medial to medial malleolus, and posterior to the posterior malleolus, and lateral to the lateral malleolus. See, now what is mortis? See, the mortis is nothing but is formed by the distal fibula plus lateral malleolus crease. Forms a deep recess are also known as mortis of the body of thallus. This is the one. See, this is the distal fibula and lateral malleolus crease. See, coming to there are so many ligaments in the ankle joint. See, the most important ligaments that we are coming to know is that medial side there will be the medial collateral ligament, and the lateral side, see, there will be the lateral collateral ligament, which I am going to discuss later. See, the medial collateral ligament is also known as deltoid ligament. The deltoid ligament has 2 parts. There is superficial layer and deep layer. And deep layer is as again has two fibers. One fiber usually runs from tibia to the navicular bone, and other fiber runs from tibia to the substantial thalli of calicalium. See, on the deep layer, the fibers usually run from tibia to the medial aspect of the thallus. This is a deep layer. See, now coming to this is the most important thing. So lateral ligament is nothing but only ligament. Is it a ligamented complex? Whenever the patient comes to you, they'll tell the pain. The ankle's pain is there. So what we should see, we should assess all the ligaments. The ligament complex is formed by anterior tibiofibular ligament and anterior talofibular ligament, posterior talofibular ligament, and calcaneofibular ligament. See, another 2 structures most commonly where the strong structures is seen in the ankle joint are anterior tibiofibular ligament and posterior tibiofibular ligament. See, this is coming to the classification. This is the most difficult classification I feel every time, but I think hopefully you will understand. This is a log Hessian classification. The spelling also I forgot in my postgraduate. I have written 100 times for this one. See, what are the types? This usually the classification is a cadaver based one, and mostly the types is depending on the force of the injury that usually occurs to the foot. The first one is supination. When foot is supinated, it may lead to external rotation injury or adduction injury. Pronated foot leads to external rotation injury or abduction injury. Next slide. Next. See, this is the pronated foot. This is a supinated foot. Supinated foot leads to external rotation injury and adduction injury. Type 1 comes to, there will be nothing, no fractures will be there in type 1. There will be the sprain of the anterior tibiofibular sprain will be there. So we can't see this in X-ray. Only we can identify it clinically. If we do examine the patient will tell pain in plantar flexion and during inversion. Coming to type 2. Type 2 is there will be a stable. This type 2 is stable fracture. There will be short oblique fracture of the distal fibula. See, this is a stable fracture. That type 3, nothing but similar to the type 2, but in addition, there will be the posterior malleolus fracture or there will be the tear of the posterior tibiofibular ligament. See, coming to type 4 is the most unstable fracture. You see, in this, why I am telling is unstable is both medial and lateral malleolus fracture will be there, along with tear of the deltoid ligament and the tibiofibular ligament tear will be there. And when foot is go to adduction, it is again of 2 types. In type 1, there will be transverse fibular fracture will be there with rupture of the talofibular ligament. In type 2, see, there is a vertical fracture of the medial malleus with transverse fracture of the fibula and will be rupture of the tibiofibular ligament. I'll show you the X-rays also. See, this is a stable fracture. This is a type 2. See, where in medially the stability is maintained. There is no any fracture like that. In laterally, there will be classical. See, here we can see the posterior superior, or there will be maybe anterior inferior fibular fracture will be there. This is a more stable injury. We can treat it conservatively. Next. See, this is unstable. This is a stage 4. In supination section, this is a stage 4. See, where medially we can see the medial malleolar fracture. If there will be 100%, there will be delta ligament injury also there. And laterally, there is a fracture of the fibula fracture is there. The fracture may be anterior, inferior, posterior, superior will be there. Now, coming to stages, I will tell briefly. I will tell the stages in supination adduction. In supination adduction, this is a stage 1. In stage 1, there will be transverse fracture of the fibula. See, this is the mortis. I told you, right? Mortis. The fracture will be below the level of mortis in stage 1. In stage 2, there will be the vertical fracture of the medial malleus. See, this is the X-ray where we can see the transverse fracture of the fibula will be there, and medially there is a vertical fracture of the medial malleus. See, here also we can see this is the fibular fracture. This, coming to this one, the most important in stage 2 in supination is we should, while operating, we should consider is that we should make the angle should be stability, we should there, and the articular congruity should be maintained, including we should correct the medial impaction will be there. That also we should correct in this. See, this is a pronated foot. See, in pronated foot, it may lead to either external rotation injury or abduction injury. See, in external rotation, again, there are 4 types. Coming to type 1, see, we can easily make out. If you know that figure and you know the movements in the ankle, we can easily classify it. That's what I understood. If you by heart it, we can't know anything. Coming to stage 1, see, in stage 1, there will be isolated medial malleus fracture or deltoid ligament will be injury, rupture will be there. Coming to stage 2, there will be this one isolated medial malleus fracture. There will be anterior tibiofibular ligament tear or sprain will be there. In stage 3, there will be medial malleus fracture, but there will be the transverse fracture of fibula or any fracture, but it will be at very high level, above the level of syndesmosis. Coming to stage 4 is nothing but similar to stage 3, but there will be posterior malleus fracture with posterior tibiofibular ligament injury. When it comes to abduction injury, there will be medial malleus fracture will be in stage 1, and in stage 2, the same like thing, like external rotation with medial malleus fracture, there will be anterior tibiofibular ligament tear or sprain will be there. Coming to stage 3, there will be the transverse or comminuted fracture of the fibula will be there above the level of syndesmosis, along with fracture of the medial malleus. See, this was diagram I want to show how the foot will be there, the mechanism. The foot is pronated and it is externally rotated. So in stage 1, there will be deltoid ligament tear or medial malleus fracture will be there. In stage 2, there will be this is a anterior tibiofibular ligament. See, it will be there, it will be here. The anterior tibiofibular ligament tear or interosseous membrane tear will be there. In coming to stage 3, there will be the proximal fracture of fibula will be there. Usually the fracture will be spiral. And coming to stage 4, see the stage 4, this is all we can see in lateral view of the X-ray. Stage 4, we can see the posterior malleus fracture or posterior tibiofibular ligament tear. See, this is the X-ray I want to show you. This is an unstable fracture where there is a syndesmosic injury is there. I already explained the stage 4. It will be the spiral fracture of the this lateral malleus, and there will be medial malleus fracture or ligament tear will be there. See, syndesmosis injury is also there. See, this is the pronation abduction. This is also stage wise. I want to explain this because the classification I feel is better to understand before treatment. Coming to stage 1, there will be the transverse fracture of the medial malleus. See, the transverse fracture of medial will be distal to the mortis. And stage 2, there will be see, this is a stage 2. In stage 2, there will be the posterior malleus fracture or there will be posterior tibiofibular ligament tear will be there. In stage 3, there will be the fracture of the fibula. It will be above the mortis. Sometimes butterfly fragment may be also present. See, this is the X-ray I want to show. It's a pronation abduction injury. See, where there is a in medial malleus short oblique fracture or transverse fracture is there, and the comminuted type of distal fracture is there, lateral malleus fracture is there. See, this Weber classification is only for lateral, this one fibula fracture. The fracture is mainly depends upon the level of fracture where the fibula occurs. See, coming to type A, the fracture of fibula will occur distal to the mortis. In type B, fracture level at the level of the mortis or at the level of the syndesmosis. In type 3, fibula fracture occurs more proximal to the mortis. See, this is the most. What is Potts fracture? See, in Potts fracture, there is nothing but easily to how to easily to remember its Potts fracture is. See, the fracture, there is a fracture of the fibula above the level of syndesmosis, and there will be rupture of the deltoid ligament. So it leads to talar tilt. See, that means talus is subluxated. I think you understand, right? See, the fracture will be above the level of syndesmosis. The syndesmosis will be intact, and there will be rupture of the deltoid ligament. It may lead to talus is subluxed laterally. What is Jupiterian fracture? It is of two types. In type 1, see, the fracture usually occurs, fracture of fibula, I am discussing of fibula, usually occurs 2 to 7 centimeters above the syndesmosis, and there will be rupture of the syndesmosis will be there, and rupture of the deltoid ligament will be there, which leads to ankle more unstable. This is we should treat them 100%. We should treat it operatively. Coming to type B, see, this is when compared to this is a low variant. Here the fracture will be avulsion fracture of the fibula will be there, and syndesmosis will be intact, but the deltoid ligament will be injured. See, what is Leaford fracture? Leaford fracture usually we will see in AP view. There is nothing but the middle portion of the fibula is avulsed at the insertion of the tibiofibular ligament. Coming to management, the ankle fracture management is we can treat them conservatively or surgically. See, before coming to what are investigations we should take, we should know. Most common investigation what we will take is X-rays and CT scan and MRI. See, whenever the patient comes to you OP and the patient will come with ankle pain, I always tell you, you will write ankle X-ray, AP lateral, AP oblique. So that's why I usually ask my PGs, what is Ottawa rules for taking ankle X-ray? This is most important. The Ottawa rules for taking ankle X-rays, because we need not. This will reduce the X-ray exposure to patient, and we can also clinically assess it. See, what is the Ottawa rules? Ottawa rules is the patient should be more aged than 55 years, and patient is not able to bear weight, and there will be bony tenderness at the edge, at the tip of lateral malleus, or there may be tenderness at the base of the fifth metatarsal. If these criteria are there, 100% we should go and take the X-ray. See, what are the X-rays we are going to take now? I'll going to discuss that. See, what are the X-rays is that AP view, lateral view, mortis view, and what and I'll discuss with all briefly what are in these views. Next. See, coming to AP view, this is the AP view we are going to take. Here we can see medial malleus, we can see distal tibia, we can see this is a tibial plafond, we can see this is a talar dome, we can see, and the lateral spots of talus we can see. Next, the most important view we always take while doing operation is the mortis view, because in mortis view we should know what all present. Mortis view usually we'll take with 15 to 20 degrees of rotation of whole lower limb. See, what all we will see in mortis view. See, this is a middle clear space. The middle clear space should be less than 4 mm, and tibiofibular overlap should be greater than 1 mm. And next one. And talocrural angle. What is talocrural angle? Talocrural angle is nothing but angle formed by the two lines. The first line is drawn between the tibial articular surface along the tibial plafando, and second line is drawn between the two malleolus. The angle formed between these two lines is known as talocrural angle. The angle should be either between 8 to 15 degrees or between 2 to 2 degrees of oppositely. Next. Coming to lateral view, what are the structures we will see in the lateral view? We will see nothing. See, what all we will see is the posterior malleus we will see, and any talar subluxation we will see, and distal fibular translation or angulation we will see. See, these are the important views. But I think in this setup we can't do all those things. What is stress views? There will be inversion stress view. In inversion stress view, we should always place the patient in supine position, and the foot is placed in a device where the pressure plate is positioned 2 centimeters above the ankle joint, and we should apply the varus stress. See, this is the plate, the pressure plate is applied, and we are applying the varus stress. If the patient is feeling any pain, we can inject 5 to 10 ml of 𝐂𝐭𝐴, so, and we can take it. See what we should see in this view, I'll tell you. Next. See, in AP view, the degree of talar tilt usually measured by angle formed by the lines drawn along the tibial plafond and dome of the talus. See, this is the dome of the tibial plafond. The angle formed that we should, right? And we should always compare this with opposite normal limb. Next. See, this is the anterior drawer stress test. This we will do in patient in prone position, and the X-ray beam should go in lateral view, lateral projection we should do. See, in this, if the separation between the tibia profundo and the talus is up to 5 mm, then it is normal. Sometimes the value ranges between 5 to 10 mm. Then we should compare with opposite limb. If the opposite limb is also same, then it is normal. If value is anything above 10 mm, it will be abnormal. See, when we will take CT, what it gives a clear picture of when it's a joint involvement, when there is a posterior malleus fracture is there, and we will coming to know about the fracture pattern. We will come to know, and we can easily pre-operatively plan the fracture, and we'll evaluate hind foot and midfoot also if needed. See, MRI usually helps you see whether there is a ligament injury or tendon injury, and any talar dome lesions is there, or syndesmosis injuries. See, coming to treatment. There are 2 options. There will be non-operative treatment and operative treatment. What are the indications for non-operative treatment? The indications for non-operative treatment is non-displaced fracture, and there will be intact syndesmosis. Either if displaced fracture is also there, if we are able to achieve anatomical motifs, then we can treat it non-operatively. And patients who are that is next. See, then coming to operative management. What are the operative we have is that, what are the indications? Failure to achieve or maintain closed reduction, unstable fracture with talar displacement or wider angle, mortise fracture that required abnormal foot position for reduction, and any open fractures. See, when we should, the most important thing is that when we should fix the lateral malleus, that is the fibula fracture. We need not always fix the fibula. The indications for fibula fracture is if fibula displacement is greater than 3 mm and fracture within 5 centimeters ankle joint, that is within 5 centimeters at the level of syndesmosis. And when there is a talar displacement and there is a complete deltoid ligament rupture, and if it is associated with bimalleolar or trimalleolar fracture, we should fix it fibula. Next. See, what is a medial malleus? When we should fix isolated medial malleus fracture, what are the indications for fixation? Usually nowadays, what the recent general is that medial malleus we should fix 100% because it may go to non-union. So what are the indications for fixation of medial malleus? There will be associated syndesmotic injury. There will be widening of the medial clear space after fibula fixation, inability to attain fibular reduction, persistent medial malleus fracture displacement after fibula fixation. See, what are the techniques we used to do is that we can fix the medial malleus with either with tension band wiring or 4 mm CC screws or medial malleus screws, or we can use the butter split. See, bimalleolar fracture. This is fracture we should fix 100% because in this fracture, both medial and lateral stabilizing structures of ankle joint are lost. See, trimalleolar fracture is nothing but there will be the fracture of the posterior malleus also will be there. So the results of the trimalleolar fracture is poor when compared to the bimalleolar fracture. What are the indications? Now I'm telling you. See, what are the indications for fixation of posterior malleus? This is the most. See, if the displacement is greater than 2 mm or if there is greater than 25% of involvement articular surface, then we should fix the posterior malleus. And if there is persistent posterior subluxation of talus. Next. See, syndesmosis injury. See, syndesmosis injury is most commonly caused by pronation external rotation, pronation abduction, and infrequently supination external rotation mechanism. Usually we will see this in Dennis Weber type C and type B injuries. These forces have caused talus to abduct or rotate externally in mortise, leading to disruption of syndesmotic ligaments. See, what is the indication? See, what are the tests we should assess? We should know to assess the syndesmotic injury. Is it? There's a stress test by external rotating the foot or Cotton's test. See, how to fix the syndesmotic injury. Their technique how to fix is that screw, we should place the screw through lateral malleus and into the distal tibia. The screw should be positioned 2 to 3 centimeters proximal to, next. See, the screw should be placed 2 to 3 centimeters proximal to the next bit, proximal to this one, and and it should place in the angle of 30 degrees so that the screw will be parallel to the articular surface. And most important thing is that we should not ask the patient to weight bear because the screw will be broken. We should remove the screw before we ask the patient to weight bear. See, the delta ligament tear, how we should assess it? Usually it occurs during supination external rotation of the foot, and we can see in AP view, this slightly there will be tilting of the trialis will be there, and there will be increasing the medial clear space will be there under in stress views. What we should do is that in this we should do open internal fixation of fibula with ligament repair to maintain the ankle mortise. Next. See, open ankle fractures. See, we should treat appropriate antibiotics pre-op in 48 hours post-op, and immediate we should clean the wound, and we should do open reduction internal fixation. Open reduction internal fixation, external fixation should be done if there is a severe soft tissue damage is present, and there will be low grade reduction results similar to closed fractures. See, what are the complications we are going to see in ankle fractures? Pre-operative, there will be mal reduction, there will be inadequate fixation, and there will be intra-articular hardware penetration. Early post-operatively, there will be wound edge dehiscence will be there and necrosis will be there, because the skin, we know that at the level of the medial malleus, there will be very tense skin will be there. It leads to necrosis like that, and infection and compartment syndrome. And what are the late complications? It may lead to stiffness. Stiffness is caused because of a prolonged immobilization, and there will be distal tibial-fibrillar synostosis will be there, and there will be malunion, non-union, and we know the post-traumatic arthritis will be there, and hardware-related complications like exposure of the hardware, everything will be there. Next, sir. Thank you.
Thank you very much, sir. Coming to the next topic, will be done by Dr. Vishnuvardhan Reddy, sir, Department of Orthopaedics, Associate Professor, on calcaneal fractures.
My topic for the day is calcaneal fractures. I don't want to dwell too deep into this matter. The contents I'm going to discuss now are in the introduction, the anatomy, the modes of injury, classifications, clinical features, radiological features, treatment options, and complications. And I have fixed a slide for recent advances. Introduction. It's the most common tarsal bone to be fractured. It represents 60% of all tarsal fractures in adults, and it consists about approximately 1 or 2% of all fractures in the human body, and this occurs mainly due to axial loading of the bone. Next. Anatomy. I don't want to dwell too deep into this. It has got a lateral surface. Next slide. Next slide. It's got a medial surface. And this is an important slide. The neurovascular bundle runs adjacent to the medial border of the calcaneum. This bundle is most likely to be injured during this trauma or during a surgery which we are likely to perform by the reduction of the sustentacular fragment, which is a key element in the surgical management of calcaneal fractures. Next. Then it's got a superior surface. The superior surface has got 3 facets: the anterior facet, the middle facet, and the posterior facet. So, next slide. Mechanism of injury. This is important. It is caused by two modes of injury. One is fall from height, That's responsible for mostly intra-articular fractures. They occur due to the talus being driven down into the calcaneum, which is composed of a thin cortical shell surrounding that cancellous bone. The second thing is motor vehicle accidents. In a high velocity injury, the calcaneum fracture may occur when the accelerator or the brake pedal impacts the plantar aspects of the foot. Third, twisting injuries may be associated with extra-articular calcaneal fractures, in particular, fractures of the anterior and the middle process or the sustentaculum. And the fourth thing is in diabetic patients, it's noticed that the increased incidence of tuberosity fractures due to the avulsion of the Achilles tendon. Associated injuries, mostly in calcaneal fractures, because the mode of that injury is such, you get to see associated fractures of the lower extremities, that's 25%, and lumbar spine injuries, 10%. And bilateral calcaneum fractures are also seen in 5 to 10% of cases. Classifications, two types. One is intra-articular, second is extra-articular. Next slide. Yes, intra-articular fractures, they include 70 to 80% of all calcaneal fractures, Essex-Lopresti classification. Primary fracture line and secondary fracture line. We have to think in these two terms. One, primary fracture line. It extends obliquely from the posteromedial aspect to the anterolateral calcaneus. It produces a posterolateral fragment consisting of tuberosity, lateral wall, and a portion of the posterior articular surface. Then the anteromedial segment consists of the anterior process, the median sustentaculum, the remaining medial aspect of the posterior articular surface. Secondary fracture line. With continued compressive forces, there is additional comminution creating a free lateral piece of the posterior facet separate from the tuberosity. It can extend into the calcaneocuboid joint, separating the anterior process into anteromedial and anterolateral fragments. It can extend medially, separating the sustentacular ligament fragment from the anteromedial fragment. Then the last thing is tongue-type fracture. A secondary fracture line appears beneath the facet and exits posteriorly through the tuberosity. Joint depression fracture. Here, a secondary fracture line exists just behind the posterior facet. There is continued axial force which causes the sustentacular fragment to slide medially, causing heel shortening and widening. Sanders classification. This is an imagery-based classification. It's based on the CT scan. This classification is based on a number of fragments at the location of that articular fragments. It is based on the coronal image, which shows the which shows the widest surface of the posterior facet of the talus. There are 4 types. Type 1, all non-displaced fractures regardless of the number of fracture lines. Type 2 is divided into 3, type 2A, B, and C. It's a 2-part fracture of the posterior facet. It's based on the location of the primary fracture line. Type 3, the 3-part fracture with a centrally depressed fragment. Subtypes are 3AB, 3AC, and 3BC. And type 4 is a highly comminuted fracture. It's a 4-part fracture. Next. Extra-articular fractures. These do not involve the posterior facet. They make up 25% of the calcaneal fractures. Anterior process fracture. These may result from strong plantar flexion and inversion, which tighten and bifurcate and the interosseous ligaments leading to an avulsion fracture. And they are often confused with an ankle sprain. We have to look very carefully into the X-ray. Next. Medial process fracture. These vertical shear fractures are due to loading of the heel in valgus. They are seen in axial radiographs. Sustentacular fractures. These occur with the heel loading accompanied by severe foot inversion. They are often confused with medial ankle sprain and are seen on axial radiographs again. Next. Body fractures. Body fractures. These are caused by axial loading, significant comminution, widening, loss of height, and may occur along with a reduction in the bolus angle without posterior facet involvement. Tuberosity fractures. These may result from eccentric loading of the Achilles tendon, especially in diabetic people, osteoporotic ladies, and rarely due to direct trauma. It's seen on a lateral radiograph. Clinical evaluation. Now, the severity of the fracture displacement and the extent of soft tissue disruption are proportional directly to the amount of force and energy involved. The lower energy injuries with minimal force produce mild swelling and ecchymosis. High velocity injuries result in severe soft tissue disruption and may result in a compound injury, compound fracture. Next. Injuries associated with the calcaneal fractures. Soft tissue injuries. One is skin blisters, hematoma, edema, and skin necrosis. Then compartment syndrome and skin necrosis secondary to displaced tongue type fractures and compound injuries. Next. Radiological evaluation. Radiological views routinely used are 4 views: anterolateral view, lateral view, Harris heel view, and Broden's view. Anteroposterior view. Though routinely done, it is less informative because too many bones superimpose on each other, the shadows. Only the, go back. The calcaneo-cuboid joint involvement can be seen. Lateral view. It confirms the diagnosis of calcaneal fractures. The important angles are crucial angle of Ghissane and Bowler's angle. In intra-articular fractures, loss of height of the posterior facet is noticed. Reduced Bowler's angle and increased Ghissane's angle is also seen. Can be used to differentiate between joint depression and tongue type fractures. This is the Bowler's angle, and that's the critical angle of Ghissane. Next, Harris axial view. For visualization of the joint surface, to assess the loss of height, increased width, angulation of the tuberosity fragment, and may be difficult to obtain due to pain. It's very difficult to position that patient. Next. Broden's view. It's taken with leg in 20 degrees of internal rotation. I'm giving a pictorial description of how that shoot is. And it's centered over the lateral malleolus. The extra beam is directed at 10, 20, 30, 40 degrees on the heel. It is used to demonstrate the articular surface of the posterior facet. Next. This is the view. This is how it is, 10 degrees. 30, 40. Next. CT scan. Coronal CT images reveal the articular surface around the posterior facet, sustentaculum, shape of the heel, position of the peroneal and flexor hallucis longus tendons. Sagittal CT images reveal depression of the tuberosity. Then axial images reveal calcaneo-cuboid joint, anteroinferior aspect of the posterior facet in sustentaculum. Treatment. In spite of all the developments we have seen in the last 20-25 years, better anesthesia, antibiotics, AOSI principles, high-end imagery, everything, this treatment is quite challenging. But the overall outcomes are considered to be good if operative intervention is done. Next. Non-operative management. Specific indications are there for non-operative treatment. Undisplaced, minimally displaced extra-articular fractures, 1. Sanders type 1. Then anterior process fractures with less than 25% involvement of the calcaneo-cuboid joint, severe peripheral vascular disease, insulin-dependent diabetes. These are the specific things. Come back 3 years for non-operative management. Next. Non-operative treatment includes this boot cast, POP cast, non-weight bearing for about 10-12 weeks, 3 months. The foot is placed in a boot cast and it's kept in neutral flexion to prevent equinus contracture. Elastic compression stockings are applied to minimize the dependent edema. Next. Operative treatment. Displaced intra-articular fractures involving the posterior facet. Sanders type 2, Sanders type 3. They require some kind of surgery based on the fracture pattern. Anterior process fracture with more than 25% calcaneo-cuboid joint involvement also, the indication is there to operate. Displaced fracture of the calcaneal tuberosity, fracture dislocation of the calcaneum, we have to operate that. Next. Selected open fractures. This is how they state. Open type 1, delay the ORIF. To stabilize the soft tissue, protect the soft tissue, we can delay it by a couple of days. Open type 2 with medial wound, it has to be delayed again. Open type 2 with non-medial wound, we can do percutaneous fixation or external fixator and hope the wound heals. Type 3, 100% external fixator or percutaneous fixation delayed. Next. Operative options, open reduction and internal fixation, close reduction, internal fixation, percutaneous fixation, arthroscopic assisted fixation, and intra-articular fractures. External fix. Finally, in Sanders type 4, gross comminution to prevent arthritis, we might have to do a primary arthrodesis. Next. Open reduction and internal fixation, preoperative planning for ORIF through an extensile lateral approach for joint depression fractures. The plain radiographs and CT scan should be thoroughly reviewed in an attempt to gain a preliminary understanding of the fracture pattern. This helps the surgeon to anticipate certain problems intra-op and prepare the technical maneuvers to facilitate fracture reduction, as well as the need for additional implants specific to that fracture pattern. Next. Surgical steps, perform an extensile lateral approach to calcaneum, use a skin hook or a K-wire, something to mobilize the fracture patterns, mobilize the lateral wall, supralateral articular fragments, mobilize the tuberosity to a primary medial fracture line, place a shank pin in the tuberosity. Next. Reduce supralateral articular fragments to the sustentacular fragment, provisionally stabilize it with a K-wire, reduce the anterior process and anterolateral fragments to the articular fragments, and to restore the Gissen's angle, stabilize again, use K-wires liberally, use it as a joystick. And then the other thing we can do is replace the lateral wall fragment. We can use bone graft, or we can use a contoured anatomical calcaneal plate. These are the options we have. Place cortical or cancellous screws. These I got from the internet. I have not seen this implant ever. Place cortical or cancellous screws through perimeter holes in the plate in the box configuration. Place cortical lag screws. Assess the stability of the superior peroneal retinaculum, then close it. Next. Open reduction and internal fixation for split tongue fractures. Perform the Essex Lopresti maneuver or the tongue fragment in an open manner. Open it. Terminally threaded guide wires from a large cannulated screw set or a 4.5 mm shank pin may be used. Then this invariably reduces the fracture fragment anatomically in the sagittal plane. The fragment can be then pinned to the sustentacular fragment and the procedure completed. Next. Minimally invasive fixation. The implants used here are Steinman's pin and a cannulated screw, done especially in split fractures, split tongue fractures. Close reduction, percutaneous pinning is done. Next. Primary arthrodesis, only for patients who have Sanders type 4 highly comminuted intra-articular fracture. After the restoration of the calcaneal body joint surface, the remaining cartilage is removed from both the surfaces of the posterior facet, and an autologous bone graft is used to perform the arthrodesis. 6.5 to 8 mm cannulated cancellous bone lag screw placed from the posterior tuberosity into the talar dome. It stabilizes the fusion. Next. Complications. I'm showing the pictorial descriptions. Compartment syndrome, wound dehiscence, calcaneal osteomyelitis. These are the most common things. Peroneal tendinitis, peroneal tendon dislocations are also noticed. Calcaneal malunion, arthritis, chronic ankle pain, heel exostosis, heel pad pain. These are all like complications. Neurological injuries, neurological problems. Cutaneous nerve injury, most common neural complication associated with operative treatment. Sural nerve is the most common nerve that is likely to get injured. The calcaneal branch of the posterior tibial nerve in the medial approach is the medial side injuries. That's the lateral part. Management. If there is a neuroma and it's painful, resection is done and the stump is buried deep into the soft tissue. Nerve entrapment is another thing. Entrapment or compression of the posterior tibial nerve is noticed. Usually during in cases where non-operative treatment is done for a fracture that is uniting in malposition. Management. A trial injection of local anesthetic into the tarsal tunnel can assist in making a diagnosis. Electrodiagnostic studies are also done to confirm the diagnosis. Operative decompression of the posterior tibial nerve and its branches may provide relief. Next. Reflex sympathetic dystrophy. It occurs regardless of the method of treatment. Pain is disproportionate to the extent of injury. Cold skin is noticed with purple discoloration. Inability to tolerate the touching of the food. They will be very apprehensive. Management. Lumbar sympathetic block, thermogram, or a bone scan may be performed to obtain the diagnosis. Intensive physiotherapy with motion and manipulation or weight bearing if the fracture has healed. Multiple lumbar sympathetic nerve blocks are administered, and finally, patient is counseled. Recent advances. This is something new. I don't know. 3-dimensional printed calcaneal fracture models are done, 3D printing, they call this as. And the bones are pre-contoured and the implant is contoured prior to the surgery on that bone model. So that is one recent advance. The other thing is minimally invasive techniques like a limited incision sinus scar-site technique, in which about 2 to 4 centimeters of incision permits a direct visualization of the posterior fragment as well as the anterolateral fragment. But these are new things and I'm not very familiar with this. So next, that's it, sir.
Thank you very much, sir. Now this concludes our lecture sessions. And our HOD sir will deal with some interesting X-rays which I have done in our institute, along with the speakers.
Sir, no need. We'll stop. No need.
So I'm just moderating this session. It will be dealt with both the speakers. Now I want to know from the other colleges, NRI has come. Huh? NRI Medical College, anybody is there here? Where is that? Okay. So that's okay. I'll call upon the final year. Suresh, can you just come over? So what we have done is, what are the complications we have done? We have put it in this. So that is what we want to learn from what complications we have done. We have put it in the X-ray here. So this is case 1. 80 years old female with trivial fall. Can you just read the slide? And what do you think is the line of treatment management? You can explain it to your speakers and they will take it from there. Take a mic. One more mic is there. Yeah.
It is a plain radiograph of right femur anterior posterior and lateral view showing the distal femur extraarticular fracture. Comes under A2, sir. According to Evo-Muller classification, it can be fixed with distal femoral locking compression bed. Locking.
So your plan is to fix a LCP, distal femur LCP.
Yes.
Okay. That is asking, are you satisfied with the X-rays?
X-rays,
Knee joint
never
also.
accept poor quality X-rays or incomplete X-rays. That is the first step. And diagnosis is important for any management.
Yes.
So only fracture is not the diagnosis.
That is why we put
You must.
for the exactly same point, we cut the X-ray and kept this. Because we knew this question will come. We thought you will ask a mixed X-ray. The first thing has been to do the X-ray. As sir said, complete X-ray and a clear X-ray should be visualized.
Many a times the treatment is determined with the poor quality X-ray or the even in a close reduction or open reduction. The CM images may not be perfect, so we will accept it because of the wrong views. So you take proper view, proper X-ray, and then determine whether they are correct or not. So when the view itself is not correct, then you will not be able to make a judgment on whether it is okay or not, or you cannot plan on a incomplete X-ray.
Yes.
We had done a thing, a distal femoral plating we had done. Because I had discussed this with, could we have just, we were apprehensive only for one reason. 80 years old lady, should we open the fracture? And if you open the joint, 80 years old, is it advisable? Or any other opinion on this? Is it better we could have gone with anything else, or is it acceptable with this?
No, it looks really very good. And this was done by MIPO. Okay. Right.
How often we use, my major question is, how often do people use bone grafting as a primary bone grafting? It's a major thing for especially like distal femur and proximal tibia. By the books, a lot of people say you should use a primary bone grafting. How often do we do that? Or what conditions we use that?
Actually, looking at the X-ray, no one will suggest for a primary bone graft in this case. It's not indicated at all. But the only concern will be only since you have already told we are presenting our complications, I'm thinking something would have happened.
No, nothing has happened for this case, fortunately. Fortunately, nothing would happen for this case, actually. But we have other X-rays which is with complications.
Okay, right. So,
next
but
one.
This one looks good.
Okay,
absolutely looks good. So only one thing is, whenever there is a medial comminution, if you don't get that medial cortical continuity, then that is a problem. So you have to aim for the medial cortical continuity. If you are able to get that, then that is fine. Otherwise, then you will have to think of a bone graft. Because it looks like the joint is also, there is an OA in the knee, and definitely this patient will have some amount of varus deformity. If she's going to weight bear accidentally also, it is going to be a stress there in the fracture site. But overall, it looks excellent.
Next one, please. So, can we get Vinod? Not Vinod. Abhinay. So these are some cases which is very difficult to manage. We didn't know how to go about this when we saw this thing. I think I had already discussed with JP one how to go about. Can read the X-ray.
So it's a plain X-ray of medial skeleton showing left distal end of femur and upper end of tibia, showing ABU and lateral view. Sir, in lateral view, we're seeing it's a Hopa's fracture, sir, of classification 3-3B3.
2 months old.
Yes, sir, 2 months old.
What is it? How do you go about it?
Sir, we have cannulated cancellous screws.
Definitely, it looks severely osteoporotic, and there seems to be some stress rises even in the distal end of the femur. Is it?
Some amount of stress rises in this kind of femur, actually.
In the lateral cortex,
Lateral
there is some
cortex,
amount of
yeah.
normally, no, the above one, Mele, is because of the quality of X-ray. Normally, you don't see that thickening in the lateral cortex in that in the supracondylar region. Commonly, that is not seen. So, whatever is it, we'll have to go and intervene, and we'll have to fix this fracture for her to mobilize.
These are difficult cases, but even this is much displaced. First, I will advise a CT, number one. And second, the bone quality is little bit poor. Yeah. So CT gives a fairly good idea about what has happened and where the fracture line lies. Even though sometimes the HOFA fragment or a posterior displaced fragment may look innocuous or minimally displaced, the patients will have severe problems. So unless otherwise you treat them, they won't be happy at all, number one. So we have to go for fixation in a 51-year-old lady, even with osteoporosis. We have good implants and good supplements available. So we have to open and we have to fix it. Probably approach would be, I think we can go in a midline approach only. We can expose the fragments. You have to clear the soft tissues. You have to attain a reasonable reduction. Then you can fix it with the screws or plates or anything.
We tried the plate, but the problem was it was too much fragments was there, and it was a very bad fracture, and we are not happy with the results what we have done post-op. This is what has happened for us. AP and lateral. This is all we could get through. Anything else could have been done for this patient, and we had put bone grafting also because it's a 2-month-old fracture. We did put bone grafting, and it was in 4 different fragments. It was a horizontal fracture was there. Anteroposterior itself was 2 fragments in the medial lateral cortex. Medial cortex also fractured like this. And as the sir said, we went through the midline approach. Because sometimes it's very, very difficult. All we wanted was a fairly good articular congruity we wanted to maintain and come out. Hopefully thinking that canceller zone might unite somehow or other. This patient is yet to come for the follow-up. We don't know. But my worry is when you start weight bearing, will it have a collapse or something? It's always a worrisome thing. And as JP was saying, the medial side sometimes tends to collapse secondarily. I mean, even with this small amount of thing. So this is a worry. Like these cases, any other options are there? Treatment?
No, there is no other treatment option. Whatever we have tried is looks reasonably good. I think so. We'll have to wait and see what happens. Probably we have immobilized this knee.
Yeah.
We can just by around 6 weeks we can start gradual mobilization, and we'll see how much of if there is going to be any collapse, and see. We can just have to wait and watch for now.
Probably we could have avoided grafting. That's what my feeling is. And that is one thing. And second thing is that fixation alone, usually in a metaphyseal region with good blood supply, will heal. And these extra bone grafts which we give usually in these areas might lead to more stiffness. And what we want to achieve is a good functioning knee. And for that, we need a good bone. And by what we have done, we can go for even a primary arthroplasty if the soft tissues are good. If at all, if the patient develops some complications or anything else. So few patients with supracondylar fracture with severe osteoporosis, like in an 80-year-old lady, what you have shown, very distal fractures, sometimes we can go for primary replacement. So we can address both the problems. One is about the fracture and another is arthritis. And second thing is that we can avoid complications, and their longevity is less. We can use, for example, 10 years or maybe 80 plus patients with severe osteoporosis especially. We have seen a lot of plate cut-throughs, screw cut-throughs, screw subsidence, and intra-articular penetration of implants.
Because multiple screws was put. The second side, if you see the lateral cortex, I had absolutely no purchase. Very less purchase was there. So all I wanted was an article congruity to be maintained and come out. As you said, sir, probably I could have avoided bone grafting, but my catch was 2 months old, and there was a huge vacuum space in the supracondylar region and all. That is why the bone graft was applied. That was the only reason. Maybe next time we will try to do, as you said, good cancellous quality of bone. We need not apply bone graft at all. That is one thing which we can learn from this. Next one, please. Yeah, this is case 3. I think we can get Bhargavi. May come up. I think this we discussed in detail in the morning from Dr. Jayaprakash. Now probably, yeah.
X-ray pelvis with both its AP views, sir, showing fracture at the left intertrochanteric fracture, sir, extension into subtrochanter, sir. Boyden Griffith, according to Boyden Griffith, it's type 4, sir. And we can go for lateral femoral locking plate, sir. Plate fixation, sir.
Plate fixation.
And you can go for PFN and can circulate.
So we have 2 options you're saying now. One, you're saying a PFN with an external stabilization, augmentation with a circlage wiring,
Yes, sir.
or you can go for a,
Cobra plating, sir.
you are having 2 options. Which one would you prefer? What reason for? Morning you heard this lecture, I believe.
Lateral cortex is not intact with that fracture. Like we can go for
What do you want to go for? PFN?
this PFN or otherwise Cobra plating is best.
I always had this doubt which I wanted to find out from JP or morning you have a lecture taken, you can put a PFN. Sometimes very thin lateral cortex, when you put the PFN, it may shatter. Has it happened sometimes ever? Because I've had experiences where when I had a very thin cortex, when I put in the PFN even, I've shattered the lateral cortex. And from there it becomes difficult.
No, yeah, it looks like that the lateral cortex is a very big chunk here in this. Definitely, if you put it on the patient interaction, the reduction will definitely be good.
This was the traction view. It looks like a big chunk, but when we went inside,
when you
this chunk was only present anteriorly, and posterior there was nothing present.
This chunk was present only anteriorly.
Anteriorly. It was like you had a horizontal fracture also. Vertical split was there along with this of that fragment itself.
This will you can definitely you can nail it. Only thing is you will have to stabilize the lateral cortex first. But you can even do a temporary circlage, and then you can nail it. And then you can put your blade. And added lateral column circlage also can be done.
So what I think we have done on contrary, what has happened actually, we have done a plating of this lateral cortex directly.
This will over a course of time, what will happen? This will definitely go into for varus.
Yeah.
The reason is this looks okay, but the length of the screw should have been much more longer. And
yeah, one mistake is that the length of the screws could have been longer for that purpose.
Length of the screws could have been much more longer. But apart from that, it looks relatively okay. This also is a good option for this fracture.
Because we tried the PFN first. When we tried the PFN initially, the same issue. When we had to put through we had no lateral cortex at all.
Sir, we never had any problem of blowing out of the lateral cortex, even if it is thin.
because the entry portal choosing is important in any PFN. And of course, the reduction is the key. First, we have to reduce the fracture. Then only we have to make an attempt to do an entry portal. So if reduction is itself is not good, then whatever, sometimes we tend to go through the fracture site itself.
Exactly.
So that is the reason once the nail is in and just you lever it out, the lateral fragment breaks. So that is a common thing which happens. Many people have told it, but reduction is an important thing. And we make an entry portal exactly through it and you ream it and then you introduce the nail. We ream the proximal fragment also. Many a times the fragment will be a little bit bigger. So if you don't ream the proximal fragment and when you enter into the nail, the reductions changes. Once the nail goes in, it pushes the fragment into varus.
Does any of both of you, when you treated a PFN A1 or A2, does it make a change? Do you decide, how do you decide what you want to do? Or do you only go for PFN A2 here onwards now?
Now we have almost completely changed to the helical blade and now to the, we are trying the screws also. Recently we gave a small study for one of our PGs to see whether there is any difference between the helical blade and the screws. The only thing is like sir told, when you try to pass your guide wire from just medial to the GT, your starting bone all might enter, but when you see, you can see your guide wire coming away. It will come laterally when you're putting your subsequent reamers. It will almost come to the lateral cortex. The lateral cortex almost will come. So what you normally do is you must take a bone awl through the guide wire and try to break that medial most part of your cortex. You will have to make that break. Otherwise, it's very, you will lose whatever you have aimed for. When you, I hope I'm able to put this pointer. See, normally you will start from here, but as you're passing your subsequent reamer, you see the guide wire will go like this. It will tend to. So what you have to do is this area, you will have to break it up. And that breaking, what you will have to take, you take a bone awl. This will be a very thick bone over here, nearly very close to the piriform fossa. You break this so that when you're inserting the nail will come at this region. If you're not going to break this part, the nail will sit over here. So that is not your aim. Let the guide wire even let it be like this. You cannot control that at all. Even though some companies, they have something which is called, they have a small lever where when you're passing the guide wire, you can lever it so that it can pass like this. There is a small tool in the some companies' instruments where you can pass the reamer like this itself. But once you put that bigger size 15.5 mm big reamer, it normally tends to fall like this. So you will have to break this corner, and that only if you break this one, then this lateral placement of the nail will not be there. Anything, sir?
Thank you, Varun. Can I get Jyotsna?
One more thing, just a minute.
Can you just go back?
And another thing which in these cases, if at all if you want to use a nail, we have to use a longer nail because it has got a subtrochanteric extension. Short nails won't work. And many people, we all think that 240 mm is a bigger enough nail, but the screw will be very close to the fracture site. And again, this increase in the length of proximal femoral nail will only produce some irritation over the cortex and anterior thigh pain, or sometimes later periprosthetic fracture. If at all, if you want to use a nail for this case, it's a very good option. And we could use a long nail. That is one thing.
Jyotsna. We just finished 1 month back. We're just following it up in here. Just hope. Yeah.
Sir, this is the anterior posterior view of the mature skeleton showing AP view and lateral view of the right knee, sir, and tibia and fibula, sir, and showing Shasker type 6 classification, sir.
What would you like to do?
I would like to go with the mypoplating, sir.
Like only the medial cortex or the lateral cortex also want to do something, or you want to, what do you want to do?
Sir, by medial cortex, sir. Lateral mypo, sir.
We did a, the thing we did was we did a medial. Lateral side, he had some lot of wound on the lateral aspect, which we didn't want to touch. That was the reason. He had a huge abrasion wound. So we had to go to the medial side. Yeah, lateral on the opposite side, lateral plate on the opposite side. In these cases also, you need to say we don't require bone grafting. No, not required. It's all whole thing. Since it's before we are not thinking of a bone grafting or anything else. We're not opening up the fracture. We just write it up. That is sort of put up in a hybrid external fixator or a reservoir or something like that. You want to manage the wound or clear up everything. So I think yeah, that lane can be mobilized here. Reservoir means they can be. Yeah, thank you. Vinay. Yeah, this is a 53-year-old female with 6 months old subtrochanteric fracture. IM nailing was done outside somewhere, and he came to us like this. IM nailing done outside, came to us like this. Can you read the X-ray? Yeah.
It's a plain X-ray of a mature skeleton showing pelvis with both hips anterior posterior view, sir, with right femur, intermediate interlocking nail implant in situ, sir, and implant failure is present, sir.
Now,
implant break.
Why do you think this implant has failed? Is this the right implant for this fracture? Why do you think it has failed?
Sir, less working length, sir.
Less working length. What could have been done that way?
Sir, long PFN. Long PFN can be.
Long
PFN. Long PFN.
What do you want to do now?
Sir, I want to remove the implant, sir.
You want to?
Remove the implant, sir. Less working length, sir.
What do you think?
It is somewhat less diameter, sir. Yes, sir, early weight bearing osteoporotic ones. Yes, sir. Yes, sir. Yes, sir. Yes, sir. Yes, sir.
What would you like to do?
Sir, remove the implants, sir, and long PFN.
Remove the implant. How do you want to remove it? You do it close or you will
First, we'll open it, sir.
Can you remove this one?
We can give it a try, sir. You can try it.
You remove the screws, you remove the
Yes, sir.
proximal fragment.
Yes,
Distal
sir.
fragment, distal part of the nail, what you will do?
Yes.
No, it does not move it. What's the position of the patient you want
Sir.
to put for this?
Fracture table only.
Post op. Acceptable? Anything can happen.
Yes.
We have it.
Yes, sir.
We don't have it. Later on. Anything on the post op?
Yes, sir. Yes. Yes. Yes, sir.
Yeah, thank you.
Yes. Thank you, sir.
Second name? Okay.
Plain X-ray of mature skeleton, pelvis with bilateral hips in AP view showing intertrochanteric fracture of the upright femur.
I always had a doubt. Oh, sir, what classification do you follow? Do you follow does all these fracture patterns fit into the Boyd and Griffin correctly, or does it not fit into? Because so many of the fractures, I feel, doesn't fit into the Boyd and Griffin at all. Many of the fractures sometimes. You might have a reverse oblique along with, subtrochanteric extension. You might have it the other way around. So deciding the treatment protocol based on Boyd and Griffin is becoming difficult actually. What would you like to do? Dynamic screw. Post-op. This is a patient now, full X-ray. You didn't ask for the full X-ray, you got this. You understood? Sir was asking you some time back. You wanted to say dynamic screw. That is why sir asked you very clearly, you should always ask for a complete X-ray. That's why we put that X-ray and kept quiet. You didn't ask for a complete X-ray. You asked for that X-ray, you didn't ask for this X-ray. Now you understood the point what sir says. Classical X-ray, this one. Now does your treatment protocol change?
Can keep direct PFNs.
You want to do a PFN, long PFN. Okay, you want to do a long PFN. But yeah, there is distal also one is there. That she has missed. So you understood. Take time to see the X-ray, ask for a full length X-ray, read the whole X-ray. Now you want to do something. You would still stick with PFN or do you want to do something else now?
Plating also, sir. Plating.
You want to do a PFN with plating of the distal femur. You want to open the fracture of the distal femur or
IT for IT fracture DHS, sir, and from retrograde nailing for distal femur and
no, behind. What about, is there something else? Is there something else? Let DFN look down. Same patient.
tibia plantar fractures. Yes.
So he's got 3 fractures now. 4 fractures, exactly speaking. He's got one in the trochanter, one in the shaft of femur, one in the distal femur, one in the proximal tibia.
We can go for plating for tibia plantar fractures.
What plating?
Buttress plate.
You want to put a trochanteric, you want to put a DHS, you want to put a DFN for this, you want to put a trochanteric, you want to put tibial plateau plate. That is our option.
And one thing is that when you see such fractures, even in ipsilateral limb, you have big bones, multiple fractures. So we have to think about the general condition of the patient, number one. So then you can decide the treatment. If it's a part of polytrauma, then probably timing of surgery and the plan of surgery might vary. For example, if there is another associated injuries, then we might have to delay it by doing an X-fix initially, or you can put them on traction for some time and wait for the general condition to improve. Then you can plan for treatment. This is like a floating knee type of thing only, along with the hip injury. So if for such case occurs, what will you do first, sir? Either tibia or femur?
This one, it's like if the skin condition over here is fine.
No, everything skin condition was fine. This patient, everything was fine. No other comorbid problems or no other injuries was there. He just transfused 3 units of blood. Sorry, transfused 3 units of blood and he was stable enough.
So then I'll start from here. So I will do a plating from here, and I'll use a 3.5 system NCP. Probably I'll add multiple two rows along with that. I'll do a lax. If required, I can put a small anti-glide plate here if it's required. Otherwise, if the stability is okay with lot of screws with metaphyseal, multiple 2 layers metaphyseal screw and 1 shut screw, I think so we must be okay. If required, we will add 1 plate here. For this one, then afterwards you can put it on traction. Probably I think I will go for a long nail, PFN nail. Then I can add a small plate over here with the nail in situ.
Why can't we do a DHS and a DFN?
We can do that also. We can do that one also. That's a different thing. So, but this is an undisplaced fracture. This is a very small fracture. So, this one with a nail, long PFN nail, and with a small. No, it will come till here. Yes. No, I'll add a plate on the lateral side. Small plate. A small plate where we can open and we can slide. We'll put multiple screws. We will have a lot of space in the posterior aspect where we can put the screws.
We have that. My question is,
That is consulted.
This is acceptable enough for we try to stabilize the medial side. Enough. Lastly, we just put a buttressing and the treatment is well.
Thing is that if such thing happens, usually we do first femur, especially around the hip. We put the patient in fracture table, and then we start from hip. Either usually we do differ. I mean, we don't address the same fractures around the hip and shaft. Sorry, you put on traction table, minimally displaced only. So usually we get a good reduction, even with the fracture shaft of femur, and when there is a neck of femur fracture also, usually we will get a good reduction in a fracture table. And we one thing is that if you want to use a DFN, we could have also used a femoral neck system for this type of cases. Even it's a small, little bit like in intertrochanteric fracture, basal neck fracture only. So the implant size will be little smaller. We can use a DFN confidently later on. First you fix the hip, then change the patient to a normal table, and then we could have addressed with the single incision, midline incision. So and then fix the tibia. Then you can go for femur plate, femur nail.
Long barrel.
As a long barrel, then, sir. So first, what we did was we made the patient lie in a supine position, sir. In the same position, we fixed the first tibia, sir, and then we put a cannulated screws from the lateral side. We put, sir. In the same sitting itself, we did the DFN, and then after that, we put the fracture table and we did the DHS. That screw also we tried, sir.
That is a good option. But you cannot support the supracondylar. It will come the.
We tried to actually put the locking screw, the proximal most locking screw for DFN. We tried to put it through the DHS, sir, but it was mismatching. So we had to end up with only 2 screws over there for DHS, sir.
One more thought is, whenever there is multiple fractures in the same bone, trying to fix it with a single implant, the chances for non-union is little higher when compared to the normal fractures. For example, if there is a fracture neck of femur and a shaft of femur, many people try to fix it with the recon nail only. So what if both goes for non-union, and what if only one goes for non-union? How will we plan it? We must think about it before doing it. So addressing separately, it is one principle, and addressing all the problems with the single implant is again another principle. So we believe in separately dealing with the problems only, because if any complication occurs with one problem, then we can try to deal with it separately. But there are people and they have got good results dealing with the single implant.
I had the same doubt. What if suppose you have a shaft of femur, recon nail, trochanter is united, and again DFN, you have to remove the nail, address the, you have one going for non-union, one for union, you might have to remove the implant for the whole thing. Same way,
No,
neck of femur, like you said, neck of femur and shaft of femur. The neck of femur goes in for non-union, and we have to remove the whole second back. Sometimes principle two implants for one thing. So 2 different school of thoughts. That's probably a chance.
Which one? No. See, that is a very tricky. See, the rule is when you have an ipsilateral fracture neck, for example, this is a trochanter. This is 100% it will unite. Yeah, there is no doubt. But if you have a neck as well as a shaft, your priority is your neck. That is rule number one. That if nobody can change it. Your neck is priority. You will have to aim for your neck. Whatever implant you is the best, you have to aim, and you'll have to get that neck correct. This definitely we can. Your best chance must be given to the neck. That is always a rule. Next one, if you are going to use a recon for the entire thing, lock it distally and hammer it, and you will not know where the screw is going to go. It's not a good idea at all. So let us forget about the recon. The recon cannot be used in this particular case. So you are saying that I'll put a recon, I'll bang it down here, I'll lock it and I reverse jam it. You do not know where that proximal recon screws are going to go there. When you're planning for a recon, your first priority will be over here. Then only you will be able to put your screws. Okay. So that is a difficulty over there. So you cannot use a recon in this case.
I mean, it should be that precise, where your proximal screw should be perfectly inside the neck very well. Distal locking should be perfect. That means you can't change a millimeter here or there to the size of the nail, size of the implant. It should be in perfect anatomy. So that is the only catch here. Okay. Next. Can I get Girija? Here's a widely treated at 85 years old patient that come treated outside. First question.
This is a plain radiograph of mature skeleton showing anteroposterior view and lateral view of pelvis. With the dynamic history of a treated for right intertrochanteric fracture, sir. The implant, there is pull out of the screw and the implant was loosened, sir.
My question is, why did the implant fail? First place. Why did the implant have failed?
So much is talked about trochanter.
Yes, sir. So there is a early weight bearing of the.
Early weight bearing in the past. Always we put the blame on the patient rather than on the, we don't take the blame. 5 months old. It's not.
Sir, lateral cortex is.
Morning when my question was, how much amount of trochanteric fracture with old age do you think of doing NER? Basis of rectal or trochanteric is coming down, 86 years old or 90 years old. Is there an option of NER or not? Is there a thinking at all of line of NER? But in this case, we not say not predict why it is because we are going to see how is the head doing? The head it's a thing that it looks like a contour is okay in this and that one. Only thing is really but anyway, it is not anything like the screen cut where you got to look for
So the neck of femur fracture, sir?
No, it goes to trochanteric fracture. Yeah. So this is the what do you do?
arthroplasty in trochanteric fractures. Of course, when we were postgraduates, we were given thesis, and we have published as a good results. But over a course of time, so morbidity to the patient increases, and post-operative deaths are common. So that we accepted this. And as the advent of new implants, now we rarely do primary arthroplasty for trochanteric fractures. Even in poor quality bone, we have good augments available, and good instrumentations and nailing systems have come. So we rarely think of primary arthroplasty in trochanteric fractures, otherwise non-pathological fractures. That is only in osteoporotic fractures. But in failure of trochanteric fractures, of course, we go for arthroplasty, and I think it's a fairly good decision. There is no other go for this case.
Yeah, this is clean cut. There's no, nobody can question other than going in for a hemiarthroplasty for this case. So this is unsymmetric stem. But this is fenestrated, no? No, this is fenestrated. No, you can see the fenestration there. And it looks like they have not put cement.
Probably cementing technique would have been a little more better. It has not come to the. This was the only option. Now the problem is, will this fail when the patient starts working? No. That is what morning when we spoke about neck of we said non-ambulatory patients or minimal ambulatory patients. This is a better option. That's what we thought.
The middle part of the neck was reconstructed by using cement.
Cement? Yeah, cement. So that might break sometimes over a course of time. That is the biggest headache.
There is one technique
you can take and reconstruct the.
You can take it and reverse damage. Reconstruct the
The head becomes a calcar.
No,
sorry, the neck of the portion reverse and put as calcar. You take the head and the neck portion, you reverse it, put the head inside. The neck will have a portion outside. That becomes a calcar.
The problem is you will not be able to put a thicker stem. So that is just
undersize the. Okay, thank you. NRI, yeah? NRI Medical College. Huh? Yeah, NRI. Can I have one page? Can you put the file there? Can I get one page? Can I get this number? The last, how many slides are there? Last two is dedicated to NRI.
Sir Maninder. It's a plain X-ray of a mature skeleton showing pelvis with both hips and also this one hip with thigh and a right leg, sir. In the pelvis with both hips, you can see there is a reverse oblique fracture of a right femur, proximal femur. Sir. Yes, sir. Subtrot. And with here in right distal 1/3 tibia and fibula fractures, fibula segmental. So for subtrochanteric fracture, I'll go with the long proximal femoral nails. Yes, sir. Here you can go with intramedullary interlocking nail with tip locking.
Long PF
Yes.
done.
Yeah, long PFN done, sir, but the reduction was not appropriate. It's in varus. And from coming to tibia, intramedullary interlocking nail was done, sir. The reduction was good. Fibula also, for fibula rushnaring was done. The nail could have gone a little deeper in tibia. No, sir, not acceptable. Usually in subtrochanteric fractures, the proximal fragment will go into flexion and external rotation, abduction, sir. So we need to counter these forces and get the cortices to each other and
Not acceptable. Not acceptable.
yes, sir. Since there is a lot of mal reduction, I'll go with redo surgery. Attaining the reduction and we can augment with subclavian firing. Yeah. Yes, sir. Since as long as the nail is in situ, we are not able to gain reduction. Yeah, keeping nail in situ, it will be difficult to gain the reduction. So I want to get the nail out and get the proper reduction.
We can do it.
That's why you would have shattered the GT. So as it's been already told, when you have a subtrochanteric fracture, this lesser trochanter is fractured. Definitely the amount of flexion will be a bit less, but this will be abducted. The proximal fragment will be abducted and externally rotated. So the main aim, it's already been told, reduce and then dream. Get your entry point correct. Your entry point should have been somewhere over in this region. If you would have got this entry point somewhere over here, definitely this would have come rotated this way and you would have maintained this. At the same time, you should have probably could have used a joystick to reduce that abduction. Probably this fragment would have been abduction and he would have not been able to reach this medial part to enter. That would have been the problem. What do you say, sir?
Yes, sir. One thing is that people always have some pride in doing a close reduction. So as far as subtrochanteric fractures are concerned, we have to reduce well before you start the entry portal. That is the important thing. And if you can maintain reduction in a closed means, then it is good. But in my experience, whatever we have, so many a times we have to open the fracture site. We reduce it, and in spite of reducing and holding, it's very difficult to make entry portal maintaining the reduction. So there are different clamps which have come to aid in our reduction and maintaining these things. So there is no shame actually in opening the fracture site. That is the first thing I want to tell. And second thing is that once you got the reduction good, and then you can start your entry portal and everything. And I think that would have helped.
So that's what, as very rightly said, I want to put to the postgraduates. Never think that anything which you did closed is a wonderful job. See, there's no problem. Don't think that MIPO is a beautiful surgery. There's no problem.
See, it's how you handle the tissue inside, which is right over the bone. There's no problem in just opening up the skin, the subcutaneous tissue. Handling the muscle and the bone is the most important thing. So never hesitate. You try once or twice. Otherwise, don't try to see if you want to reduce this fracture, you want to put a pin, don't try it so many times. You will spoil this entire bone over here. So if you're not getting it in the first time, that is fine. If you're not getting it the second time, don't hesitate, just open it up. You will be able to do a beautiful job by opening it. The most important thing is you will have to just handle the soft tissues very well. There's nothing wrong in adding even a big incision if you want to put from the proximal end to the middle end for reducing a fracture. There's no harm at all. Only thing is handling the tissues is very important.
It's a very valuable lesson. For the newer generation, they always, brag saying they have done in a small. Towards the end, what is the final functional outcome of the patient? I believe, right? What I do is I spend 20 minutes of close production. If I don't get it, I open it. I don't go beyond that. My time limit is maximum 20 minutes. I try for 20 minutes. If I don't get it, I go into it. What have we done for this? Now, we have done this. Is it acceptable? This is what we have done. You said you wanted to go for a defense mailing or mailing is very difficult. Once there is that already there's a practice. Another practice period is to shatter out the whole thing. One more technique, again to remove for a division.
Yeah. The only thing is what was done over here. You should have actually packed this area with a good amount of bone graft.
I think they had put bone graft. Huh?
No, it doesn't look like there is nothing there. No, actually, see, in subtrochanteric fractures and along the medial shaft, you must have a good continuity of the bone. If you don't have a good continuity of the bone, and with the plate over here, this will definitely fail. If it is going to be a nail, at least you might think that, okay, we can give a chance. But if it's going to be a plate, and that too, you can see that the screws are, you see, you just imagine that you're going to put they are taken a bone graft here. They are taken both sides.
It is bone graft. No. Not done.
Huh? Ella?
Looks like a bone graft done by that. Telling the people, the median most important bone grafting. Yeah, I told them that I very good amount of particle cancer. With particle cancer graft, also the particle cancer graft, then probably right.
Yes, yes.
Is what I believe. Role and also
Longer one. And rules in always in metaphyseal, whenever you are trying to put in metaphyseal diaphyseal fractures, you must try to fill all the metaphyseal screws as far as possible. When you have a fracture in this region, you must try to fill most number of screws possible in this region. Metaphyseal, diaphyseal, even in the supracondylar, here in the proximal humerus, you must always aim that you fix a maximum number of screws into your head wherever possible.
Hoping for when it comes for thank you so much. With the lady a chance. all complicated which we had. We did that. So that is what is important. So you're saying what you have done the best.
Good afternoon, sir. My name is Lalita. This is an X-ray of left knee joint showing distal femur and tibia and fibula, distal femur comminuted fracture.
Everything you look at it. Only a distal femur.
Distal femur, patella, and proximal tibia fracture.
Patella and patella.
Yes, sir.
Another couple of months, you guys will be consultants. All of you, finally 6 months. What will you do?
For distal femur lawful plates and lateral side bicondylar. Dual plate.
What femur?
Distal femur.
How often you have seen a medial condyle plate? What is the reason? What's the reason?
If there's going to be a combination in the medial supracondylar region, then I normally use a small plate that side. Otherwise, most of the plating, if I'm going to get a good continuation of this, so yes, in this you may not require.
Maybe.
No, that's correct. So you can kind of have a good continuity of the medial cortex. And this is probably looks like it's coming from the lateral condyle, lateral cortex wall.
That's what we got as patella. That's why I told you to look at the lateral. Too many implants and everything. Do the math. It's like too many implants are there.
Other are good, well done, sir, actually. Usually these will be open fractures and with the discontinuity of the quadriceps. So many times the proximal fragment will pierce through the quadriceps and it will come into the subcutaneous tissue or sometimes pierce the skin and come. But anyway, management will not differ. If the wound is clean, then you can go for a primary internal fixation. So, and what I have seen in many of your X-rays, sir, today is you put all the screws in the plate. So, which is not needed, I think. You can space the screws and a bigger plate with less number of screws will also serve equally, and it will be better than using a short plate with all screws. That's the current concept. But I think other things are very good only. So here you use a locking canceller screws, sir.
This week, last case, yes, can. Yes, can. NRI. Finished 7. Always a challenge. Now, the problem is we get such cases, and people say, patients come and tell us the same fracture, the other fellow was treated somewhere. Our sorry to tell you, but our enemy is always Chennai. If Chennai, if it is that, because this problem is if they go to any corporate in Chennai and the results are bad, then we can ask them, they can the sentence back to us. If they have got it bad in Chennai, imagine what would happen if you are operating in Chennai. That is the underlying line we get.
Good afternoon, sir. This is a plain radiograph of a mature skeleton showing the ankle joint, and it's showing bimalleolar ankle fracture communicated. This with intra-articular extension. Tubular plating of the fibula, sir. Okay. First, we need to primary stabilization. Sir. Primary stabilization, sir. Angle spanning external fixation can be applied. Spanning external fixator. Once the wound and everything healed, then we can go for primary and next internal fixation, sir. Fibula, I can go for plating, sir. Plating and distal tibia plating, sir. Plate, distal tibia plate. And for fibula, it's a choice, sir. We can go for either a 1/3 tubular plate or a brush nail.
One thing is that when you see such an X-ray, you have to don't decide on X-ray alone. You have to ask for clinical history, what has happened, and you have to assess the violence, that is the nature of injury, and if it is trivial, and if you see such a X-rays with big deformities, so you have to ask further history and everything. So you have to rule out neuropathy foot. That is the number one. Many a times we decide on X-ray, and then we see that the patient is having neuropathy, and you whatever you do, and we land up with failures. So better to get good history, good examination, as are told, open fracture or closed fracture, the vascularity, skin condition, and then decide on treatment. So
this is what we could manage. Come back to us. It is going to be a good challenge.
Actually, look at the pre-op. It is a very, very thin, very thin bone over there.
Let's go back to the X-ray, sir. So initial management is okay, sir. But what will you do next, sir?
I would rather suggest this is very severely badly comminuted. What is going to, you can go in for a primary arthrodesis in this case.
Putting him through output pain and arthritis and again multiple surgeries.
Yes, yes.
If it is a closed fracture.
No, even if it is open, he is a young adult, and arthrodesis would be a good choice. Good choice for him.
He will say whatever he put is good. Anything else?
Sir, one thing is that we can see we can do arthrodesis, that is there, but of course arthrodesis can be done only in cases where there is no infection, at least number one. So because even in infected cases we have done arthrodesis, especially in diabetic foot, but the chances is that again it gets complicated. So one is that if the skin conditions are good, and if he doesn't have any other comorbidities like rheumatoid arthritis, he's a young fellow, that's what you told. So force of violence is high. This is tibial plafond fractures actually. So intra-articular fractures, we can get away sometimes with good screws from yes, sir. Graft we can keep. Yeah, that is one thing, sir. And you can do a buttress plating also. And another thing is that we can little bit give a good reduction and compression using a tension band wire instead of only K wire in the initial stages itself. So that is these are options which could have been done. and definitely not plate in the initial stage when the bone skin condition is not good. And of course, we do have got an arthrodesis of various types. You can either do a tibio talar arthrodesis, or you can go for Blair fusion, or you can whatever fusion is an option definitely in this patient here. And another thing they say is you can actually do a Elizero type of fixation for such patients primarily. You can use with wires, you can reduce the plafond and you can maintain it, and you can put a foot frame, and gradually you can remove the foot frame and mobilize the ankle. So, but anyway, the ankle is going to be stiff only, that we have to accept, and whether it will be painful or painless, and whatever range of movement what we get, that is what the bargain is. Little bit range of movement will help actually, but eventually I believe that these patients will land up in fusion. And many stiff ankles with problems in X-rays, they may not have pain. That also we have seen. Yeah. So we can, I think you can save the ankle a little bit. You can try one more try, and then if no thing is there, then we can plan for arthrodesis.
When we are actually planning for any procedure, if that fails, if we have an answer to that, there's no that you can definitely try that procedure. So if you don't have a secondary solution, then don't try that. So that's how. So you can give a try. If you can tell the patient that if it's going to fail, then there is no other option. We can go ahead. And because the subtalar joint is going to be supportive, only thing is not have dorsifrontal subtalar joint movements will definitely help him. So he will do well.
So that comes to the end of our discussion. Hope it was interactive good enough. You know, I think, Azhar. So we've come to the end of the session in the program. At the outset, I would like to thank the management at the administration and the support staff, and most importantly, my postgraduates and faculty, and my interns too, who have been helping us all around, and most of my interns have been here still yesterday night, taking care of things and doing the work. Thank you so much. I have not seen interns doing so much for us, but thank you so much for the interns, postgraduates, and the faculty and everybody. And a special thanks to the two people. And both of them, whenever I give a phone call, I've never heard them say no to me. Hopefully, because I also don't want to call them frequently to hear a no. So thank you very much, sir. Dr. Jayaprakash and Dr. Natarajan, sir, thank you very much. And I hope it has been an informal session. This is like, we have started this initially complex trauma of the lower limb. It's like Bahubali part 1 is over. Part 2 is upper limb. So we are still directing it now. So we'll just wait for it. Anyhow, thank you so much. I think we'll have a small felicitation for both of us, chief guests, and then we'll end up the session. Thank you so much. I forgot to Spencer, a special thanks to the main sponsors who have been supportive all the way through. Srinivas, thank you so much. It was a wonderful gesture from your end with a short notice helping us through. And thank you so much. And all my faculty, I think Dr. Bhargav, Neil and all have been staying all the way throughout the night. sending me pictures at 12:30, 1 o'clock in the night and everything. Thank you so much, all of you. Without this, without all of your support, this would not have been possible. Thank you so much. And special thank to the NRI batch, who have come all the way. I think Balu must have stressed a bit on you people. So come all the way. Thank you so much. Yeah.
Now I would like Dr. Biju sir to felicitate Dr. Jayaprakash sir. Thank you, sir. Now I would like Dr. Natarajan sir to come up to the dais, and I would like Dr. Biju sir to felicitate Dr. Natarajan. Thank you, sir.
More people to
Please have it and go. Thank you.